চলে আসছেন ম্যাডাম। আচ্ছা, অসুবিধা নাই, এর মধ্যে উনি চলে আসবেন। চলে আসছে, উনি চলে আসছে পরে পরে।
Distinguished guests, participants from home and abroad, ladies and gentlemen, welcome to our session and good day to all. These are Dr. Umme Tania Nasrin and Dr.
বাপ্পি দাস।
We are welcoming you all to our 9th session of our second International Conference of Maternal Fetal Medicine Society of Bangladesh. Our session is on prematurity, which is an unavoidable issue but is quite important in our daily-to-daily management of high-risk pregnancy. As we know that prematurity and its complications is still now the leading cause of prenatal mortality in our country. And this is a quite important issue of and also a goal of our fulfilling SDG target.
In this session, we have two chairpersons. Our first chairperson, Professor Kohinoor Begum Madam. She is a senior OBGYN specialist in the field of Bangladesh, past president OGSB, professor Obs and Gynae, Popular Medical College, former professor and head of the department, Dhaka Medical College, vice president and counselor, BCPS, vice president, Bangladesh Perinatal Society, and also so many organizations. She has a lot of experiences in the management of high-risk pregnancy and also has lot of works. Our another chairperson is Professor Deepi Borua Madam. She is also a senior OBGYN specialist and also has a vast experience in the field of high-risk pregnancy. Madam is now newly appointed as a director, Holy Family Red Crescent Medical College and Hospital, ex-International Affairs Secretary, OGSB, Entertainment Secretary, PCOS Club, Bangladesh, EC member, Endometriosis Society of Bangladesh, and Gynecological Oncology Society of Bangladesh. Now, I am requesting our honorable chairpersons to come up on dais and take their seats. Thank you, madam. Now, we have in this session two eminent speakers from home and abroad. Our first speaker is Dr. Anita Kaul, head of the Department Fetal Medicine, Indraprastha, Apollo Hospital, New Delhi. And our next speaker is Professor Nujhat Choudhury, who is also from Bangladesh, Bangabandhu Sheikh Mujib Medical University, and she is a professor of Vitreoretinal Department of Ophthalmology. Each speaker will get 20 minutes for their session, and I am requesting the speakers to end their presentation in time. If time permits, we will take the question answer session. So if you have any question, please note it down and we will take it at the end of the session. Now, I am requesting our chairpersons to conduct the session.
আসসালামু আলাইকুম আপনাদের সবাইকে স্বাগতম আমার এই আজকের সেশনে আজকের সেশন today's session is on prematurity very important as the reporter says and we have two eminent speakers and their topics are ROP and prediction and prevention of prematurity. Our first speaker, Onita Kaul, she'll be talking on prediction and prevention of prematurity. She is the head of the Department of Fetal Medicine, Indraprastho Apollo Hospital, New Delhi. She is specialized in fetal medicine, in vitro fetal therapy, lasers, invasive diagnostic tests, twins, prenatal screening for maternal and fetal complications. Her topic is preterm labor, prediction, prevention. Dr. Onita, please.
Thank you, Dr. Begum. Thank you, chair people. And you'll be pleased to see that the slides are working today and there's no glitch. So preterm labor, the prediction and prevention is really close to my heart because the problem with preterm labor is that the majority of women who end up going into preterm labor, it's spontaneous pregnancies. There's, but a substantial proportion is also iatrogenic, and these are the group which we are sort of focusing on because as we discussed yesterday, pre-eclampsia contributes a lot to FGR and preterm birth. So again, for obstetricians, for all of us, the problem is that this woman who's come to you pregnant, how do you predict that she'll go into preterm labor? And why it's important is because of the health implications to the fetus. And, Dr. Nuzhat will talk about one of them, the retinopathy of prematurity. The other thing is, of course, that it's so expensive. In India, in our countries, it's difficult to get cost implications. But a Canadian population, because they have much more, their sort of data collection and epidemiological collection is much better than in our countries. And you can see that a huge amount of money, huge amount of the national budget in countries which have got the national health system, a huge amount goes in looking after these babies. So where are we in terms of trying to diagnose and where are we in trying to predict preterm delivery? So if you look at the history and how research, because preterm labor was so important that there's been for years there's been research into preterm births. And I'm going to quote some of the slides. I'm taking some of the slides from Professor Roberto Romero because he spent actually a lifetime doing research into preterm births. So it all started because we thought that, well, what preterm labor is just that the uterine contractility starts early before it should. And the initial research was all about trying to suppress the contractility by using calcium channel blockers and a whole lot of other variety of agents. And it was realized that actually you were not making a dent into the cases being seen. Then it was realized that no, if there's intra-amniotic infection, it's not just contractility. If there's intra-amniotic infection, that contributes to preterm delivery. And then we started using antibiotics and thought that, well, will that help? And then we realized that no, even that doesn't help so much. Then the research came into, is there any sterile? They may not have infection, but they may have sterile inflammation, that there's inflammation of the in utero environment, and that's why antibiotics don't work. And that's why tocolytics don't work. And therefore, what was basically realized that actually the physiological pathways in spontaneous labor is fundamentally different to pathological ones. So the way we were extrapolating, because a lot of research was, well, we know how term labor works and we just extrapolate that and bring it down to preterm labor. And it was realized that actually it's not as simple as that. Preterm labor is more of a syndrome where you have all these things contribute to it. And all of these various problems, which include cervical disease, which includes inflammation, which can include allergy, sort of allergy-like insults, a whole lot of them, they all have this common pathway where either there's an increase in uterine contractility, or there may be cervical insufficiency, or the membrane decidual layer that gets activated, and it sort of results either in preterm labor or a short cervix or preterm prom. So then logically, what are the things that we can do? Perhaps we can use tocodynamometers, and check for uterine contractility. We can use ultrasound to look for the short cervix, and we can use biological biomarkers like fibronectin to see, has this membrane decidual glue, has that separated, and we can look for it in the vagina and use fibronectin as a predictive value. Amongst all this, it was also realized that a subset of patients actually have reduced progesterone action, and in this particular group, we realize that vaginal progesterone helps. So the problem is that there is so much heterogeneity in the way preterm labor happens that it is very, very difficult to have a single method of predicting preterm labor. But without doubt, the thing that is the most effective is universal screening using cervical length ultrasound. So much like yesterday, universal screening for preeclampsia is important. For us, as important as preeclampsia is predicting preterm labor using cervical length ultrasound. So all of you know that there's no way this woman can go into labor unless her cervix opens up. And we know that normal cervical length is between 35 and 40, and you can measure it and you can see. And we are currently using a cutoff of 25 mm, that if the cervical length is less than 25 mm, then she is at risk of preterm labor. So if we say that cervical length is important and that is what we should be measuring, what is the way we should do it? What we shouldn't do is do abdominal measurements. What we should do is transvaginal. And in women who perhaps may not want transvaginal, transperineal is also useful, but you need to use transvaginal scans. So again, for all of you who are, whoever your favorite sonologist is, when they go for the anomaly scan mid-trimester, please tell them that they have to measure the cervix at the same time, and they need to do it transvaginally. And when you do it transvaginally, this is what it looks like. You can see a nice cervix, you can measure the internal os and external os, and this is what it looks when it is a short cervix. You can see there's funneling. What we can see on ultrasound is the internal os. What you cannot see it when you do a digital examination. You have no knowledge of where the internal os is. So you have to use ultrasound to look at it, and you can see that this is a short cervix, and this is practically an open cervix as well, so whatever. But time and time again, meta-analysis has shown that using vaginal progesterones, and all the groups are saying the same, that progesterone helps. So this is where we are as far as short cervix is concerned. Now, what about intra-amniotic infection? And I'm going to illustrate this with a case which we had, 28, this is just a typical case. She did have a previous history of spontaneous vaginal birth, so we were much more alert with this woman. She was low risk. In the first trimester, this is her cervix. It was 33 mm. And then when she came for the anomaly scan, because for us it is routine practice that we check the cervix, we noticed this intra-amniotic sludge, but we still had a nice cervix. Now the thing is that intra-amniotic, in this case, because of intra-amniotic sludge, and you know what intra-amniotic sludge is whenever you're scanning, suddenly in the ultrasound you see lots of this hyperechogenic matter. And again, if you are not scanning, please tell your sonologist to look for this. It's really very classic. And but we sent a swab, we did a grand statement culture, it came candida, we treated it, but because of her history, called her back. You could see this intra-amniotic sludge much more. This, I don't know why, all this is all sludge. And the next thing we know is that she went into preterm labor and she had a repeated mid-trimester loss. So what we realize and what the research shows is that this is a marker, one for intra-amniotic infection, but the key point over here is that the organisms which are involved are totally different to the ones that we are used to. We are used to our usual vaginal swab. So it is possible that you may do a normal vaginal swab, it comes back as normal, but actually she still has infection, she has all this. Now in the West, and these are Professor Romero's slide, is that our routine tests are not good enough to test for it. So what they do is they look at the interleukin 6 on the amniotic. So they actually do amniotic fluid taps and they look for infection, look for interleukin 6, look for metalloproteinases. But I mean, for us, maybe it's not so practical. But this is the antibiotic combination that they suggest, that maybe whenever you have sludge, and there is a short cervix, you feel that this woman is more there's more of a risk that she may go into preterm labor. She, then this is the sort of ceftriaxone, clarithromycin, and metronidazole is a better combination than the things that we are using. The third thing is, how do you predict membrane decidual separation? Because that's the other thing we have in our armamentarium. The fetal fibronectin is essentially a glue which keeps things together. And if there is separation, you can look at it in the vagina. So we have the actin partus in India. Do you have actin partus here? So these are like vaginal, it's very, you can just buy it. There's so many pharmaceutical companies. Maybe one of them becomes a distributor for the fibronectin kits. But essentially it's like taking a swab and you wait for 15 minutes. And so unfortunately we have a qualitative way of checking that like a pregnancy test, the color changes if there's fibronectin. But in the West, they have moved beyond just checking on a color. What they've moved is to quantitative. So what the test kits, they don't just look that is there fibronectin there or not. They look what is the quantity of fibronectin. And there is an app which I'll tell you about, which is Professor Shannon's app, and you'll be listening to him a little bit later on because he's done a huge amount of work on preterm labor, is you can predict things, and I'll come to it in a minute. So anyway, for us, there are mainly for all of you, we have like 4 clinical situations which we want to discuss. One is the asymptomatic low-risk women who come to us, and they form 2/3 of our population. One is the asymptomatic, currently asymptomatic, but she's a high-risk person because she had previous preterm birth. Twins and multiple pregnancy, always a worry. And anyone who comes to you in the labor ward with threatened preterm labor, what should you do? And I'm just telling you the Fetal Medicine Foundation protocols because, again, Professor Nicolaides and group, they have done an enormous amount of research work in here. So as is known, is that we have iatrogenic preterm labor, that is obstetricians getting the babies out too soon in 40% of cases, and that is not good. Whether it's because of preeclampsia or whether it is they lose confidence and they get the baby out. So, you know, we really need to look at this. As I said, preeclampsia is important. Vaginal progesterone helps. So currently the recommendation is in the first trimester, screen for preeclampsia and treat with aspirin as we discussed yesterday. And in the second trimester, when they come for the anomaly scan, check the cervical length. And if the cervical length is more than 25, you monitor her as, you know, do usual. If it is less than 25, start her on vaginal progesterones. Then re-scan her after 2 weeks and check the cervix. If the cervix is stable, continue progesterones until 36 weeks, as FIGO says. And if it is still decreasing, do a infection screen first, do a vaginal swab. I mean, in our case, we also do an actin partus. So before putting a stitch, we do a vaginal swab. We check for fibronectin, make sure everything's okay before we put in a stitch. Because if you sometimes put in a stitch and she still goes into preterm labor, then it is thought to be a failure of the stitch, and it could be that it was inevitable. But anyway, so then you can put in a cerclage. And this is what FIGO also has suggested as a best practice in fetal medicine, that you follow this protocol. Then you have the second group, which is that they have come to you that they've had a previous preterm birth. Or it could be that they have some other problem, that maybe they have some uterine anomalies, but I mean, that's a separate lecture in itself. So in this group, we do exactly the same thing. But in this group, we are much more proactive, that we do 2 weekly ultrasounds starting from 14 weeks up to, continuously till 24 weeks. But here, we don't wait for the cervix to become less than 25 mm. Here, if she reaches the anomaly scan mid-trimester, we proactively start progesterone for the rest of the pregnancy, for the second half of the pregnancy. That means from 20 to 34 weeks or 36 weeks, you start her with vaginal progesterone 200 mg. And if in this interim time, you find that the cervix is also getting shorter, then in that case, you put in a cerclage. So in the women with the previous preterm birth, follow them up. Don't do a stitch immediately. Follow them up from mid-trimester on. Start them on progesterone. If in the interim time, any time that the cervix becomes less than 25, put a cerclage. What about twins? Twins is the other group where, we are, it's too random, the treatment. Like in Delhi, I know some IVF people do it routinely, that they put a stitch in others. Some follow with serial scans, some do nothing. So the point is, what we have in our hand is progesterone. And how good is progesterone in twins? The reality is it's not as good as in singletons, which these studies have shown. So again, the Fetal Medicine Foundation had done, Professor Nicolaides had done a huge trial where they look to see that if you start early vaginal, which is what actually a lot of obstetricians do anyway. As soon as you have someone with twins, they put them on vaginal progestogens. So if you give vaginal progestogens versus placebo in twin pregnancy, and start at 11 to 14 weeks and give it till 34 weeks and give a higher dose, 600 milligrams, not just 200 as we use in singletons, did that make a difference? And the reality is that it didn't. So, things that we were doing, if you see over here, the difference between vaginal progesterone and placebo was practically the same, and they, looked at a huge amount. So the analysis was that, okay, it may not help hugely, but what it does, they have suggested there's this shift hypothesis theory. That means that these women who were anyway going to go and deliver, say if they were going to deliver naturally maybe around 22 weeks, the 600 milligrams of vaginal progesterones would not take them beyond 34 weeks, which is our definition of of preventing preterm labor, because you want them all to go beyond 34 weeks. But at least they would reach around 30 weeks. And the ones who would have delivered maybe at 28, 30 weeks, if they were on vaginal progesterones, maybe they would have shifted to more around 34 weeks. So currently, our thoughts are that if you have twins, start them on vaginal progestogens, but a higher dose, 600 milligrams. And if at any time, the other thing which resulted from the study was for twins, we changed the definition of the cervix length. We made it much more bigger. So where we are taking 25 mm for singleton pregnancies, we are using 30 mm for twin pregnancies. So the thing is, you start them on vaginal progestogens, you do 600 milligrams, you do with a higher dose, you still do serial cervical lengths. If the cervical length is less than 30, you add, the other way around, that once you start them on progestogens, and if your cervical length becomes much less, and despite progesterone, it's not maintained beyond 30 mm, you put in a stitch. Okay, so that is the sort of main groups. Now, this particular group, which I'm particularly interested because I think we are doing it absolutely wrong, and which is giving steroids unnecessarily. And the problem with obstetricians is that as soon as they have preterm, a woman complains of threatened preterm labor, they immediately either call up their registrar or call up whoever and say, well, at least give her antenatal steroids until I reach and check. This is very common, and this is considered suboptimal treatment. So when it was realized that actually all these people who were ending up getting steroids, they actually still went on and delivered beyond 34 weeks. It was thought that it is suboptimal treatment if delivery occurred more than 24 hours later, and questionably appropriate treatment. That means that you're not doing your job properly if, despite giving steroids, that pregnancy went on to beyond 35 weeks. And this is important because now, as more and more research is coming in, and this is the Green Top guideline which was released in February 22, the RCOG guideline, and please all of you read it, which is the antenatal steroids in pregnancy, because a lot has changed. The problem is that they think that now there is neurocognitive and neurosensory disorders in these babies who are getting steroids because the white brain matter plasticity gets restricted with steroids. So where we used to give it much more liberally first, I mean, if I can avoid giving steroids in pregnancy, I really do that. If they reach 34 weeks, so that means the late preterms, the 34 to 37 weeks, again we avoid it, and you need to speak to the couple. I mean, each couple needs to be told that there is a small risk of neurodevelopmental abnormality if you receive steroids now, because most of the brain gets developed in the last month. So if you receive it now versus RDS, versus transient tachypnea of the newborn, which I feel the nursery can handle, and should you be giving steroids at all. So the timing is important. As I said, most of them deliver. So the point is that when she comes with threatened preterm labor, please just check the cervix. If you put in so she's on the ward, you first check her cervix as soon as she comes in. Her cervix is long. She's nothing is going to happen in the next couple of hours. So you monitor her. You've got the CTG. You can look at the tocologist. You can give her antitocolytic agents and see if she settles down. If she settles down, why will you give her steroids? You also can repeat your cervical length after a couple of hours to see is it shortened. So you have to give it appropriately, so you withhold unnecessary steroids. This is Professor Shannon's app, and this is something that all of us should use. As I mentioned yesterday, we have to go beyond clinical history. We have to start doing personalized risk assessment for every patient. We have to become familiar with using software algorithms. This is a free app which you put on your phone, and literally what he's done is that when that patient comes to you, you fill in all this. Is there, abnormal premature? Has she had surgery? Has she had preterm birth? Blah, 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 all these things. You put in a cervical length. If you have fibronectin, you put that in as well. And what that app tells you is that what is her probability of going into spontaneous preterm birth. So you will get this information. Well, it's 7% or 29% or whatever. So this woman who's in front of you, you can sort of customize whether you need to give her steroids, whether you need to do an in utero transfer to a better nursery. You can do much more. I don't know if he'll speak about it, but I would tell you to check it out. So my take-home message is that we need to do universal screening for preterm labor. And at the moment, the best thing is the cervical length measurement. So thank you very much.
Thank you. Thank you, Dr. Anita, for a very nice and excellent presentation, which will help us to our day-to-day practice. Preterm labor is very important. It's a topic for us because it is one of the important cause of neonatal mortality and morbidity. So it has extra burden to economic impacts and also the national health effect. So, but unfortunately, there are no such single test which can predict or prevent the premature labor. But for our low resource setting, we can use cervical length as a predictive test because and it must be done transvaginally. So if the cervical length is below 2.5 centimeter, then we can have some treatment pump. For treatment purpose, if the cervical length is below 2.5 centimeter and she has no previous history of preterm labor, we can only give her progesterone. But if the cervical length is 2.5 centimeter and she had previous preterm labor, you can put, and progesterone doesn't work, you can put her on Sarclase. So, thank you very much for your nice presentation. It is very informative, and thank you.
Actually, I feel very honored and blessed to act as a chairperson in the same event with Professor Kohinoor Begum, who is the past president of Obstetrical and Gynecological Society of Bangladesh and also Counselor of BCPS. Our next speaker is Professor Nujat Choudhury. She is the Professor of Vitreoretina, Department of Ophthalmology, Bangabandhu Sheikh Mujib Medical University. Fellowship in Vitreoretina of Isfahani Islamia Eye Institute and Hospital, Bangladesh, and IV Prasad Eye Institute, India. Her topic is the challenge of ROP in Bangladesh and the road ahead. Professor Nujat Choudhury, please.
Honorable chairpersons of the session, moderator, distinguished audience, Assalamu alaikum, and a very good morning to you all. It's an honor and privilege to be able to present here in front of such an esteemed audience. So I'm going to talk about the challenge of ROP in Bangladesh and the road ahead. I have no financial disclosures. This picture tells it all. The mother was crying just the last week. The patients came to my chamber. She repeatedly asked me, why did no one tell us? Why did no one tell us that we needed to come to the doctor, an ophthalmologist, Why did no one tell us that we needed to do that within a month? See, these two children, sisters, such beautiful babies, were born in a renowned Dhaka clinic, in a clinic in Dhaka, delivered by an esteemed obstetrician, taken care of in her clinic, in her NICU, by an esteemed neonatologist. Yet at 4 months age, the mother saw something white in the eye. And when she finally came to us, there was very little we can do. We asked surgery to be done. By then, she had lost all faith in us. So she went to India, they operated. She still makes them wear specs. I didn't have the heart to tell her that her daughter in yellow dress will never see the light, and the daughter in pink dress will hardly be able to see light and shadow good enough to go to the toilet. So we are still giving them the vision therapy. You know, why did this happen? This happened because we are not aware of the magnitude of the problem. See, in case of premature delivery, Bangladesh is 7th in the whole world. Obviously, we are a very highly populated country. 8th in global population, 1/5 of the live births are preterm, and that leads to about a whopping more than 600,000 premature births per every year. So how many of them will have ROP? Not all, certainly not all. In one of our in-house research, we found that 23.7% of the babies born in BSMMU, Bangabandhu Sheikh Mujib Medical University, and treated in NICU there, with all the good care and blending of oxygen, 23.7% had some sort of ROP. Not all of them will lead to blindness, and not all of them needed to be treated. But to find out how many there are, you need to screen 100%. This is something we need to understand, that we need to screen 100% of the babies, because you cannot tell which baby is going to get ROP and which baby is not going to get ROP. So every year, because we are not aware, 28,000 preterm babies are at high risk of blindness due to ROP. See, what has happened is that the story of ROP is story of development. As we are getting better economically and academically, our perinatal care, our antenatal cares are getting better, infertility treatments are getting better, you are able to deliver younger and younger preterm children, and the neonatologists are able to keep them alive. But only staying alive is not our aim. If they're alive, they need to see the world. Such special care units are being developed all across Bangladesh, and we therefore did a GIS mapping, and we found that 127 neonatal units and 106 ophthalmology units are there that requires the ROP screening. But if you can look at this, only 4 NICUs, even in Dhaka city, has a regular routine weekly screening. Many has random irregular screening where there's a child, we are called, but regular weekly screenings are what we are asking for. So we must understand what is retinopathy of prematurity, both me and you, because it is affecting both our children. Retinopathy of prematurity is a unique vasoproliferative disorder. It's unique. It happens to the premature children and low birth weight children only. It affects the avascular part of the retina, where, because there's no oxygen, it secretes VEGF. When the child is in the womb, it is in a relatively hypoxic status. So when it comes out and breathes in oxygen, it's in a relatively hyperoxic status. So that gives rise to VEGF. That suppresses the VEGF that is causing the growth of the vessels. If I show you the later slide, in retinal vascular development, At 4 months, that is 16 weeks of intrauterine life, the actual retinal vasculature starts to develop, and they develop in a circumferential manner from the disc towards the aura, from posterior to anterior. So you see, if a child is born here, say 34 weeks, 32 weeks, 28 weeks, you are able to even keep them alive at 26 weeks. So such a large proportion of retina remains without vessel, avascular, but a living tissue cannot live without oxygen. So they start releasing VEGF. And that VEGF, the vascular endothelial growth factor, goes to these arteries at the periphery and the capillaries and the venues, they stimulate them to have endothelial growth. New vessels grow, but new vessels are not good vessels. They're leaky, they're fragile, so they leak, they bleed. They don't do any work. They don't supply oxygen or nutrient. Rather, we know that a vessel has fibrovascular element. So the vascular element comes with its fibrous component. It contracts. And therefore, there is a circumferential RD initially. From there, there's a tubular closed funnel RD. And at that stage, there is nothing we can do. Often when you ask us to screen the babies, you'll find certain words like zone, extent, stages. Let me explain. The closer they are to the optic nerve, the zone 1, the worse the condition is. These are seen in the extreme low birth weight and very premature babies. Then zone 2, and this is zone 3, which is rather better. In case of stage, there are 5 stages. There has been recent in this year's certain subdivision in stage 5. I'm not going to get into it. Let me just explain what we see. When we do indirect ophthalmoscope, there is a demarcation line. So this is the healthy vascularized retina. This is the avascular retina, immature retina. The problem is beginning to show. So now there is a ridge. It's getting up. It's no longer going there, no longer supplying. Rather, it's going towards the vitreous. This is how the new vessels go. And now they will cause bleeding. Now they will cause problems. Worst of all, now they are going to cause traction. This is how the retina becomes a closed funnel RD. We operate on them, but even in the best possible care all over the globe, the visual outcome is very poor. When you see something like this, something white, mother sees or you see, that is when the case is already lost. There are other points we write, like plus disease, where you cannot dilate the pupil, cannot see retina. These are very bad signs. So I'm not going to get into details about it. It's that this is what a normal retina should be in a neonate, and this is what we see. But worst of all, there is something called APROP, which from this year we are terming AROP. You can see there is no pattern. There's like a syncytial pattern of vessels. You can't really make out which one is artery, which one is vein. So this is the worst kind of ROP. This is called APROP or AROP. It does not follow any stages and zone. It develops very rapidly. It usually happens to the more younger, more low birth weight children, the children who had ventilator and they had ventilator service, CPAP, or had blood transfusion, multiple births, sepsis, PDA, PFO in the heart. So they usually have this, and remember that they will go blind within hours to days. They don't have 30 days. They only have hours to days to go blind. So it's very important for you and I both to know the ROP screening criteria. If you listen to nothing in my lecture, just please keep these things in your mind. We have a 30-day strategy and we have a 20-day strategy. The 30-day strategy is for the 35, any child born at or below 35 weeks and or, which means either of the problem is sufficient enough for me to screen the baby. So at or below 35 weeks and or at or below 2000 gram. We need to see the baby at least once before 30 days. But in case of those that are born before 28 days, at or before 28 weeks, and or below 1200 grams, and now from this year we have changed the criteria to 1500 grams. So any baby born at or below 1500 grams and or at or below 28 weeks, we need to screen them at 20 days. If you send these babies for screening at 30 days, they will already be blind. So we need to understand that. And we must understand that you can screen as well. Your senior staff nurse can screen as well. You don't need to always call an ophthalmologist. You can train whoever is in your NICU, neonatologist, it can be, we can go, you can screen. We just need to be efficient in doing indirect ophthalmoscopy. So anybody who has a hospital, has a NICU without an ROP service, you can send your technician even, your senior staff nurse, just to do the screening. When they see the danger signs, the plus signs, they can send the baby to us or ask us to come. If not, if you give a call to the ROP specialist, he or she is bound to come and screen. And for your information, in Dhaka, NIO does free screening. Treatment is also free. Bangabandhu Sheikh Mujib Medical University does free screening. Treatment is nominal. There's Bardem, there's Islamia, there's private centers. There is one in Mymensingh now, BNSB. There is the CITC Pahartoli Hospital in Chittagong is doing ROP screening. There's one in Cox's Bazar, Deep Eye Care in Rangpur. I'm telling that for your benefit so that you can refer the baby. So the factors that increase the risk are respiratory distress, sepsis, blood transfusion, multiple births, apneic episodes, intravitreal hemorrhage, or any index, anything that makes the pediatrician worry that this child can have ROP should be screened. So how should we prevent? Accurate prediction and prevention of preterm birth. You had a lovely discussion just before me. Use of antenatal corticosteroid. Before 34 weeks of gestational age, it has role in preventing. So this is good for those that are below the 34 weeks cutoff point. I just learned from our esteemed colleague. And we must prevent injudicious use of oxygen. This is so important. You know, immediately after birth, even if the Apgar score is good, sometimes we give oxygen. No need. And you know, if you have an NICU, you must have a blender. Oxygen must be at 88 to 93%. And you must always have an pulse oximeter monitoring the oxygen saturation. Anemia of prematurity cuts both ways. If you have anemia, that is bad. And for us, it is 10 milligram per DL. I know that the neonatologists call it 7, but we ask for transfusion if we see ROP is getting worse. Weight loss or slow weight gain is also a problem. So there has to be routine ROP screening in NICU, mandatory. NICU or SCANU without a ROP screening is only going to give birth to blind babies. There's no point to that. Proper and timely referral and proper and adequate counseling, not a seal given. Just go to your an eye specialist and ENT specialist for screening. Not like that. You have to tell them. A lot of mothers come to us and tell us that we didn't understand it was so serious. So you must do the counseling properly. So is there treatment? In Bangladesh, I'm happy to tell you, in BSMMU, in NIO, in private centers, all the current high-end services are there. You know, whatever you get in a global format, you now have in Bangladesh, including the vitreoretinal surgery. So we do the laser photocoagulation, there is injection anti-VEGF, but those cases 4A, 4B, and 5, we are doing vitreoretinal surgery. I mention again, it has very poor outcome. So what is the rationale? The rationale is that when you ablate or, the stimulus is coming from the hypoxic avascular retina. So VEGF is rising up. So if you ablate that avascular retina between the aura and the ridge, you are saving the already vascularized portion. So you are sacrificing that for the cause of vision. Otherwise, the child will go blind. So the treatment options, cryopixia are no longer used. So laser, the treatment of choice, and also there is anti-VEGF, which is almost like a miracle drug to us. We treat these babies in NICU. We do very confluent lasers. This is how it looks after laser. Intravitreal injections are frequently given, and intravitreal, laser, you lose a bit of peripheral vision. In injection, you increase the peripheral vision. So that's a very good option, but there are also risks to that. And this is how we do a surgery. If I've done, we have done laser before, but now doing surgery, but it's not going to give good vision. So where do we stand in case of ROP? So we did a situation analysis in 2015-16, and we saw that the situation was very dismal. In peripheral government medical college, 800 babies were eligible for the screening. None was screened at that time. 38 babies became blind subsequently. So there are many challenges for a country like Bangladesh. Inadequate service, mostly Dhaka-based service. Even in Dhaka, most of the NICUs are not covered by ROP services. In a country of 160 million people, less than 60, in fact, not a 16 people do ROP on a preferential basis. So very inadequate resource. And none of the pediatric ophthalmologists or general ophthalmologists are actually doing it now. We don't have any mid-level ophthalmic personals doing the screening like optometrists, no formal trainings facility. So you need to know indirect ophthalmoscope, and nowadays RedCam and laser being given to the peripheral medical colleges, but not properly utilized. So service is very inadequate, as I said, but the most important part is lack of awareness. We don't know how bad the situation is. Not among only the general population, amongst us, doctors too. So we did a knowledge attitude practice study with London School of Hygiene and Tropical Medicine and Orbis. We found that nurses even don't have any idea, the management do not have any idea. Doctors have the knowledge, but very little practical experience. So just imagine the general population has no idea. We don't have the proper documentation facilities, inadequate research is there, no national survey is there. So we cannot actually put forward to the policymakers the problem. We cannot tell you how big the problem is. So overcoming the challenges, what are we trying to do? Obviously, we are trying to build awareness. We are going to the farthest corner of this country. We are giving talks among the ophthalmologists. We are coming to the neonatologists. And now we are coming to the obstetricians. We must prevent premature delivery. And if there must be one, it has to be in a NICU. The baby has to reside in a NICU that has ROP screening. So advocacy events are very important, but capacity building, I told you that 160 million people, not 16 people actually do that as a matter of preference. So we are trying to build up capacity. We are training our next generation. We are training master trainers who will go to the districts and divisions who will train furthermore ROP specialists. So we are doing workshop. Our last workshop in 2022 had 181 participants. So from 16 people, now we will have hundreds of people. That's a good news. But the best news is that we had a national symposium in 2016. I don't know if you can see, but the Neonatology Forum president, the OBGYN president, everybody was there. We further had more national symposiums where we brought in all stakeholders like you, like neonatologists, like the NGOs, policymakers. So that resulted in establishment of 12 more ROP centers across the country. We are decentralizing, as I already told you. And also we have formed a national technical committee. I was happy to be a part of it. we have already formulated the national guideline for ROP screening. We have developed 8 ROP indicators, and we have managed to include them in district health information system, which will make it an organized system where no baby will fall out of the net. So that these are the national indicators. I don't think it's important here. We have developed some promotional materials. We have and now the government has made a national steering committee. I'm a part of it, and there are national advisory committee. So I hope that ROP service will gain momentum. So the way we are trying to operate is that, see, BSMMU is going to be the hub. We have already given 8 red camps where you, in the regional medical colleges, all your medical colleges, and these red camps, the technician or whoever is operating it is only going to take a picture, send the picture here. Not all the mothers have to come to us. It's expensive for them. Only those that we say are at risk of developing ROP at a scale where they need treatment. Not everybody who develops ROP will need treatment. Most of them will, it is a self-limiting disease in most cases, most of them will not require treatment. So by only seeing the picture, we can tell only the 10% of children, neonates, who need to come to us. So this is the hub and spoke model of the KidRub format that I was talking about. So this is what we are trying to incorporate in our country. So we have made the hub in BSMMU. We have inaugurated it recently. So that's going to be the national resource source for teleconsultation, basically also training and collaboration. All the public-private partnerships are important with Orbis, UNICEF, and USAID, everything. So UNICEF has outlined 8 strategic action plans for ROP implementation in Bangladesh. We have outlined the roles of all stakeholders, and I am here to talk about your part in it. Not only referral, what would be the best, the ideal situation if there was no premature birth? But there will obviously be premature birth, but we can try our level best so that there is no premature birth. If there is a premature birth, it should be at a place, the baby should reside in a NICU or SCANU, which has oxygen blending capacity. No NICU should be there which gives 100% oxygen. We must blend the oxygens. We must blend the oxygen. We should not give unblended oxygen ever. And other modalities I've already talked about, and screening must be there. Regular routine screening must be there. So the tragedy of ROP is that at birth there is actually no disease. It's a treatable condition, but the blindness is untreatable. But this blindness is needless. Once a child becomes blind by 1.5 to 2 months, is going to remain blind for 70 years. But there is treatment available in Bangladesh, but the treatment must be given on time. It is a race against time, and the responsibility, the onus is with the neonatologist and the obstetrician to send them to the ROP specialist. So let's join our hands in a way so strongly so that not one single baby goes blind because it was born a little too early with a little less weight. Thank you all.
Thank you, Professor Nujat Chaudhary, for your excellent and informative presentation. Retinopathy or prematurity is an eye disease that can happen in babies of prematurity and also babies OAs 1.2 kg or less. ROP happens when abnormal blood vessels grow in the retina. Some babies with ROP have mild cases and get better without treatment. But some babies really need treatment to protect their vision and also prevent blindness. Professor Nujat mentioned that an eye examination should be done and mandatory. As Bangladesh progresses economically, better perinatal care and increasing number of NICUs are helping premature babies to survive. With that, the rate of ROP is increasing in Bangladesh in an alarming rate. If it is diagnosed early, it can be treatable. As in Bangladesh, so many initiatives are taken. I hope in near future the incidence of ROP will be low. But I think one thing is very, very important, which is awareness. And Dr. Nujat also mentioned nicely. Awareness should be developed in the mass population as well as within the doctors also. I think many junior doctors, they don't know what is ROP and what is the grave consequences of ROP. Thank you. I would like to give again thanks to Professor Nujat.
আমি একটা 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 কথা বলি এখানে যেটা বলা হলো যে রেসপন্সিবিলিটি কিন্তু যেহেতু বাচ্চা আমাদের হাতে প্রথম হয় প্রিমেচুর বেবিটা রেসপন্সিবিলিটি কিন্তু আমাদের যে আমরা এতদিন ওয়াকিবহাল ছিলাম না অত কেয়ার করি নাই বাট দিস ইজ দ্য টাইম যে আমাদের হাতে যেন একটা বাচ্চাও খারাপ হয়ে না যায় আমরা যেন ব্লেম না হই বাই সামবডি যে ওদের জন্য বাচ্চা খারাপ হয়ে গেছে সো আমার রিকোয়েস্ট থাকবে বাচ্চার ওজন 1500 গ্রামের নিচে বা 2 কেজির নিচে অথবা ডিউরেশন যদি প্রিমেচুর হয় তাহলে উই মাস্ট ইনফর্ম দ্য আরওপি স্পেশালিস্ট অর ইনফর্ম দ্য পেডিয়াট্রিশিয়ান ফার্স্ট যে টেক কেয়ার অফ দি আরওপি থ্যাংক ইউ ভেরি মাচ অসংখ্য ধন্যবাদ
Thank you, madam, for your valuable comments regarding the speakers. We are almost at the end of the session. Now I am requesting Professor Kohinoor Begum, madam, to give the appreciation certificate to our first speaker, Dr. Anita Kaul. Thank you, madam. Now I am requesting Professor Deepi Borua, madam, to give the appreciation certificate to Professor Nujhat Chaudhuri, madam. Thank you, madam. I know you have so many questions regarding this fruitful presentation of our two eminent speakers, but due to shortage of time, we are not taking any questions. Sorry for that.
Now I would like to Professor Kohinoor Begum Madam to give a book written on high-risk pregnancy, which is we know written by pioneer of fetal-maternal medicine in our country and also great obstetrician, Professor Firoza Begum, which is recently published by JP Brothers. Please, madam. Thank you. Now I would like to request Professor Deepi Borua madam to hand over the book to Professor Kohinoor Begum madam. Thank you.
Now this is the end of our session. Thank you for your patience hearing. Thank you.
Thank you all.
Distinguished guests, ladies and gentlemen, participants from home and abroad, a very good day to you all and Assalamu alaikum. This is me, Dr. Umme Salma, and me, Dr. Soheli Nargis. Welcome you all in the 10th session of our second International Scientific Conference of Maternal Fetal Society of Bangladesh. Our session is on imaging in maternal fetal medicine, which is very important and non-invasive tool for prenatal evaluation. Along with Doppler, which provide the information about fetal hemodynamic status, provide significant role about managing the complicated pregnancies.
We are honored to have two renowned chairpersons with us,
Professor Ferdowsi Islam Lipi, currently working as a professor in Popular Medical College and Hospital. She was the founder of Fetal Medicine Unit of Dhaka Medical College and Hospital, and she was former professor and head of the Department of Dhaka Medical College. Our another chairperson, Professor Gulshan Ara, who is the Chief Consultant OB-GYN, BRB Hospital, Dhaka. She was the former head of the Department of Sir Solimullah Medical College and Enam Medical College. She is Secretary General OGSB, Secretary General Pediatric and Adolescent Gynecological Society of Bangladesh. My humble request to both the chairperson to come up on the dais and take their seat. Professor Ferdowsi Islam Lipi and Professor Gulshanar ma'am, please come. Dear audience, in this session, we have two eminent speakers with us, Professor Vatsal Dadwal from India and Dr. Shakil Ahmed. Second speaker will join us by Zoom link. 20 minutes are allocated for each speakers. Please try to complete your presentation in time. If anyone has any question, please ask it at the end of the session. So it's my great privilege to request my chairperson to conduct the session.
Assalamu alaikum. Very good afternoon. Now we are going to start our session 10, Imaging in Maternal and Fetal Medicine. We have two renowned speakers in this aspect, and we should learn so many things from them. Now I am hand over the mic for Ferdowsi Islam Lipi to start the session.
Assalamu alaikum. I am happy to introduce Professor Vatsal Dadwal, Professor and Unit Head, Maternal Fetal Medicine Division, Department of OBGYN, All India Institute of Medical Science, New Delhi. She is a graduate and also an MD from the same institution, and she is actively involved in different portfolio in Society of Fetal Medicine and Society of OBGYN of Delhi. She is also a very good researcher, having more than 160 publications. Her special interest in fetal medicine, specifically diagnostic and therapeutic interventions, and also in ultrasound, especially anomaly screening in all trimester, and also fetal echo. Now I request Professor Dadwal to present her paper on first, second, and third trimester ultrasound, when and what to look for.
Thank you, ma'am, for the kind words. It's a vast topic, but I'll try to cover some salient points. And I don't know, I think with the specialty of maternal fetal medicine coming up, more and more OBGYN would be doing their at least growth scans and early pregnancy scans. But even if you're not doing scans, we should know what to ask for and what to look. Always check the images that are of good quality. The report is given properly to make so that it makes meaning to us. So we know that ultrasound is essential part of obstetric care. So as maternal fetal medicine specialists, we have to arm ourselves with this tool, and it provides information to give optimum outcome for the mother and the baby. And as the pyramid of care is inverting, early pregnancy scan, that is first semester scan, is giving us a lot of information, and we should take advantage of that. So not only we need to know when to do the scan, what to look for, how to document it is also very important, and the principles of safety for the fetus. So a little about how it has evolved. Till 25 years back, routine scan in pregnancy was not a thing. So the studies conducted in the 90s, the American trial showed that if you do a routine scan in the second trimester, you detect 31% of anomalies. The Eurofetus group showed 60% detection rate. And finally, a consensus was reached in 1997 to say that every woman should have a scan between 18 and 22 weeks to screen for congenital anomaly. Further advances, better machines, and a lot of work by Professor Nicoloides, we moved to first trimester scanning, and 2011 was the introduction of nuchal translucency for aneuploidies screening. Moving forward, anomaly scan in the first trimester. What about third trimester scan? what we understand, most of it is limited to growth. So the principles of safety is that you're exposed to as little as desirable, but as little as required to do your scan meaningfully, and avoid using Doppler in the first trimester. So coming to the first trimester, we know we look at viability, we use this for dating and to look at the number of fetuses, identify the chorionicity, amnionicity. Moving beyond, we are looking at the aneuploidy screening, detecting gross anomalies, and also screening for preeclampsia. So what is the best time to do one scan in the first trimester, which will cover all our previous aims? That is between the 11 to 14 weeks. But let's look at the first trimester landmarks. By doing a transvaginal scan, we see the structures much earlier than transabdominal because we have a higher frequency transducer, which is more closer to the area of interest. So you can see a gestational sac as early as 4 to 4.5 weeks of pregnancy. Important to distinguish between a double ring sac to a single ring structure like this, which is lying in the endometrial cavity, is just a fluid collection and not a true sac, because if you have to rule out an intrauterine sac or you're suspecting ectopic. As pregnancy advances, you see the yolk sac, you start seeing the embryo as early as 5.5 weeks, and you're seeing the cardiac activity at 6.5 weeks of gestation. So when do we say that the pregnancy is failed? If you have a crown rump length of 7 millimeter or more and you don't see a cardiac activity, or the mean sac diameter is more than 25 mm without an embryo on a transvaginal scan, you would say that the pregnancy is failed. What are the measurements we do in the first trimester? We do the mean sac diameter before we see the fetal pole. Once we see the fetal pole properly, we can do the crown rump length, preferably after 8 weeks of gestation for dating. Again, there are proper plane and proper guidelines as to how the measurements have to be taken to be more accurate. There are other measurements also we can do, like the biparietal head circumference, that we usually do around 12 weeks onwards. So the importance of doing a CRL measurement in the first trimester is dating, because that is the most accurate way of dating a pregnancy. And once you have assigned a dating based on first trimester scan, you would change a date only if there's a difference of more than 6 days between the menstrual age and the gestational age by ultrasound. And once you have assigned an age by ultrasound, you will not change it based on subsequent scans. Other ways, other times you may have to do a scan is when you really want to confirm a pregnancy, like it's after an IVF or infertility conception, you suspect ectopic, the woman has come with bleeding or vaginal bleeding or pain, or clinical suspicion of a GTN. So we have moved beyond dating and viability to aneuploidy screening, and that is done between 11 to 14 weeks. And the most important component is doing nuchal translucency. Again, not to emphasize that it is very important that the measurements are done in the proper plane, following the Fetal Medicine Foundation guidelines for doing it, because if you don't do it properly, a slight error in the measurement can make your reports will come wrong, and you would be over or under diagnosing any screen positives for aneuploidy. So nuchal translucency is this fluid space behind the fetal neck. This is what looks like normal. It may be increased, and it should only be done by a trained person so that we have proper measurements. And again, or you have this fluid-filled space around the neck, which is so large around the body when you say it is cystic hygroma. Again, we have guidelines, we have planes in which has to be done. So even if you're not doing the scan, if you're looking at the image, if a patient has come with a nuchal first trimester scan and an NT has been reported, please see that this is what the plane looks like and the measurements have been done properly. Otherwise, it has no meaning. So any value above 3 mm or 3.5 mm, we say it is increased NT, would call for a invasive to rule out a chromosomal anomaly. But what is important, we should also report NT as centile values for that CRL, because the absolute value may be less than 3 mm, but more than 99 centile for that CRL, and again that becomes significant. Other markers of aneuploidy that we're looking is the nasal bone, where you can see in the same plane and in which you're doing the NT, looking at tricuspid Doppler, looking at the regurgitation, and also looking at absent or reversed A wave in the Doppler of the ductus venosus. So YM emphasizes again and again should be done in proper planes, properly by a trained, radiologist, because it is an integral part of your first trimester screening, and it is a most important component of combined screening. If you don't have a proper NT, your image is not good, you are not sure that the readings are done properly, don't go for first trimester screening, because the biochemicals are not good for first trimester screening. It has to be NT, biochemicals, and maternal age. And adding the other markers of aneuploidy would increase your detection rate. So what we do is follow a triaging system. You can use age, NT, and SEMO markers. If the woman is high risk, you can offer her invasive. If she's low risk, she goes out of the screening. If she's intermediate risk, we can add the other markers of aneuploidy, like looking at the nasal bone, DV, and TR, to reassign her risk. And if she's still high risk, she can either go for an IPT or she can go for an invasive. We know increased NT is associated with chromosomal abnormalities in the fetus, and as the NT increases, the risk of anomalies, chromosomal anomaly increases. In a chromosomally normal fetus, we have to look for structural abnormalities. That also increases as the NT increases. Not only that, NT is a marker. Even if there is no structural abnormality, no chromosomal abnormality increase, NT means that there is a higher risk of adverse pregnancy outcome. So up to 10% of euploid fetuses with increased NT have congenital anomalies. So we have to look at the cardiac anomaly, which is the most common. And there is a whole long list of structural anomalies, genetic syndromes, which can be associated with increased NT. So increased NT in a chromosomally normal fetus means that you do a scan there and then, like in the first trimester, to see for any anomalies. If you can't, repeat a scan at 16 weeks, again at 18 to 20 weeks. Try to look at the heart also to rule out structural anomalies. Same, increased NT, absent or reversed A wave, or a TR is basically a pointer towards cardiac defect, even if the fetus is euploid. Other things which are signs which you can see on first trimester scan, a pointer towards anomalies are, you should look at the intracranial translucency, which is this filled space here, which is a future fourth ventricle. So this is normally you see the brainstem, the fourth ventricle as the IT, and this is a cisterna magna. If you have a fetus with spina bifida, you don't see these lines. So if you see something like this on a mid-sagittal section, look for a neural tube defect. Or if you find a big cystic space, then you have to think of posterior fossa anomalies, and again look for these things carefully. So when we're doing a first trimester anomaly or the anatomy scan, we know that we can detect some major anomalies. The advantages are that we can detect early, refer the mother for genetic testing, and if it is a gross anomaly incompatible with life, she has a choice of terminating the pregnancy early. We can image the entire fetus in one view, and the mid-sagittal view that you see gives you a whole lot of information, not about markers of aneuploidy, but also structural anomalies. The bones are less ossified, so you can see the structures well. The baby is moving, so you can see the baby in many planes in a short time, and you can use the transvaginal approach. But the limitation is the fetus is small, the organs are very small, and not all anomalies can be picked up at this time, because some of them only manifest later in the second trimester. So the societies have given a checklist when you're doing the anatomy scan. We need to understand the embryology as to what anomalies we can see and what we cannot, and understand the limitations. Here is one of the checklists as to what are the different structures in the fetus that we can see in the first trimester anatomy scan. And a systematic review has shown you can pick up to 50% of major structural anomalies even in the first trimester. And there's certain which we should not miss on the first trimester scan is anencephaly, prosencephaly, major anterior abdominal wall defects, megacystis, hydrops. So these are some of the anomalies like a clubfoot. This is showing omphalocele, and this is showing acrania. And this is a holoprosencephaly, a single monoventricle should not be missed. But we need to understand a normal first trimester anatomy scan does not mean that all is well. It has to be followed up with the second trimester anomaly scan, because not all anomalies can be detected, especially the ones of the CNS, lungs, GI, renal, and many of the cardiac tumors. So when you look at the first trimester ultrasound, you can go by the checklist and look at the different organs, but just to give an example, how important it is to understand what you're going to see, the fetal embryology, how the fetus is developing. Because if you look at the head in the first trimester, you hardly see any cerebral cortex. You just see fluid-filled ventricles and the choroid plexus, which is normal. So if you don't know the embryology, you don't know what structures to look for, you will think maybe the ventricles are dilated. As in the second trimester, you can evaluate the whole spine, you can look at the face. This is a coronal section of the face where you can see the mandible, or that is the maxilla, which is the hard palate. A defect here or a gap here would point towards maybe a cleft palate. So if you're looking in the mid-sagittal plane, if you don't see the whole maxilla properly, as you call as a maxillary gap, you have to look for a cleft lip, cleft palate. Similarly, you can even diagnose microcephaly and other facial anomalies. Heart can also be seen, and color here is important because the heart is so small. If you see a line like this, you know that the atria, there are two atria, two ventricle, and that fourth chamber looks normal. Y sign means that the two large arteries are seen and they have most probably a normal course. On the abdomen, you can see the cord insertion. If it is normal, there is no omphalocele. Here is a stomach you can see, then you can see the kidneys, you can see the bladder. So limbs, all these can be seen. So a survey of the anatomy can be done. How much you can do will depend on your expertise and also your machines and other things. When we do a scan and we find a multiple pregnancy, it is not enough to give a diagnosis of a multiple pregnancy. We have to look at the chorionicity and the amnionicity. And that should be done best after 7 weeks in the first trimester. So we look at the number of placentas, we look at the intertwined membranes, and we look at the number of yolk sacs. If you have two placentas and a thick membrane and a lambda sign, that is a bit of the chorionic tissue is going in between the membranes, that is a dichorionic pregnancy. If you see single placenta and a very thin membrane, it's a diamniotic pregnancy. If you don't see any amnion, that means it is a monoamniotic pregnancy. It is important to diagnose them as monochorionic or dichorionic because the follow-up, the complications are different for both the pregnancies. Another important thing, if you find a CRL discordance, it could be a pointer to aneuploidy or TTTS. Use a CRL of the bigger twin for dating the pregnancy. If there is increased NT beyond aneuploidian anomalies in a monochorionic, we should think of maybe she can later develop TTTS, or look at the other fetus carefully. Is it a trap? Labeling is important for following up the fetuses later. This is the best time to look at the uterus and the adnexa, because second trimester it may not be very easy to visualize, and also look at the placenta. Don't give a diagnosis of a placenta previa because we know it's very early to say. As the uterus grows, the placenta moves up. Look at any subchorionic collection. If it is large, it should be noted and followed up. If the patient has a previous cesarean, look at the placenta. If it is in the lower segment, even in the first trimester, you can diagnose a past disorder or see if the sac is implanted very low, just above the internal os, in relation to the isthmus or the bladder. It could be a cesarean scar ectopic. So the whole world of information that we can get from a first trimester scan. Coming to the second trimester scan, which we are much more familiar with, we know we do it to do the gestational age, the numbers, the anatomy, the placenta, the amniotic fluid volume, and like Dr. Anita said, a transvaginal scan if the patient is consenting for the cervical length as a predictor for preterm birth. Formal assessment of uterus and adnexa is not a part of second trimester scan. So who should have a mid-trimester scan? Every woman should be offered a mid-trimester scan as a part of routine pregnancy care to rule out any anomalies. Ideally between 18 to 24 weeks, but sometimes you have to also see the local legislation. Depending on at what period in gestation, medical termination is advised in case there is an anomaly. So we have to do the fetal measurements. These are the measurements we take. Again, it is very important that the images are clear, see that they are properly magnified and measured, and they are taken at a proper landmark as given by the societies to have a meaningful value. So for biparietal diameter and head circumference, we can take in the same plane where you see the cavum, you see the two thalami and the midline forks. And for femur length, we should avoid measuring the epiphysis, only the diphyseal length, otherwise you'll get an erroneous value. Again, for the abdominal circumference, we take in a plane where you see the stomach, we see the portal vein, and we see only one rib on both sides. That means it is a proper plane, otherwise the values are not accurate. Transcerebral diameter is another dimension which can be used for dating. So as you see here, if you do your dating as pregnancy advances, there is likely to be more error. So the best time to date would be in the first trimester. If you miss that, then only you look for dating in the second trimester. So all the fetal biometry has to be measured in absolute numbers as well as the centile values to see if it is falling within the normal of your growth charts, whatever growth charts you're using, if it is more or less depending on the centiles. Amniotic fluid assessment can also be done in the second trimester and should be done. Oligohydramnios may be a marker for anomalies like renal anomaly. If you find a filamentous or marginal insertion report, there is no value for doing a routine umbilical artery Doppler in second trimester. You may do a uterine artery Doppler if you're screening, if it is a part of screening for preeclampsia. Again, multiple gestations, if we see for the first time in the second trimester, it may be tricky to assign chorionicity. If you cannot, you can also look at the fetal gender. If they're both same sex, more likely to be monochorionic. If you're not able to make out, treat them as monochorionic. Again, their checklist, this is the iceberg checklist as to what are the desirable things that you should see on an anomaly scan and what you should be seeing actually, and a few which are desirable. So anatomical survey is important, and they have given the planes in which you have to see. So for head, there has to be 3 planes. You can look at the face in the coronal, in the mid-sagittal. For every organ, you should look in at least 2 planes to avoid missing an anomaly. Neck, thorax, heart, you have to see. 4-chamber view, if you look at all the pregnancies, you will detect 50% of the congenital fetal heart defects, but you improve it to looking at the outflow tracts and also the 3-vessel trachea view, you'll pick up more than 80% of the cardiac anomalies. Again, abdomen, you can look at the stomach, cord insertion, same as for in the first trimester scan, the spine. And the limbs also should be, all whole segments, all 12 bones should be recorded, and the hand and the feet. Also, location of the placenta, see the distance from the os. If it is more than 2 centimeter of the os, it is fine. If it is within 2 centimeter of the os, it is low-lying. If it is covering the os, then we have to follow to see if it is actually placenta previa later or if it moves up. So these patients will require a follow-up scan. So if you have a patient who has a placenta previa or a multiple placenta previa or a multiple gestation, you should also look for vasa previa and placenta previa with previous cesarean. If you're doing a second trimester scan, you have to rule out PAS. And this has already been discussed earlier, and again cervical length. So coming to the third trimester scan, there are a lot of indications for doing. So most of the time we are doing it to assess the growth and the fetal well-being. But it could be also a follow-up scan for previous anomalies, for placental position. If a woman comes with history of bleeding per vaginum or leaking, we do a scan to look at the liquor, the placental position. We also do for follow-up to see if a woman has come with decreased fetal movements, or to look at the liquor and also do a biophysical profile for fetal well-being. It may be a follow-up scan for a small babies, for multiples. For multiples, we have to do regular scans every 3 to 4 weeks for growth, because clinically we cannot monitor them. And also in women who have a previous small baby, previous bad obstetric history, pre-eclampsia, we also have to do serial growth scans in the third trimester. So in the growth scan, we do the biometry. We have to plot them on population charts and look at the centile values, whether it's less than 10 centile to say SGA. If the SGA, we do the Dopplers to classify them whether they're growth restricted or just small and healthy, which already was discussed pretty well yesterday. Then again, there are some indications. So either like most of us may even do one routine growth scan for low-risk pregnancy in the third trimester, or we would do a growth scan if in a low-risk pregnancy, if we find there is a discrepancy between the clinical examination and the gestational age. Routinely, we would do a growth scan for pregnancy who are at higher risk of FGR. Women with hypertensive disorders, I think that got repeated. So some anomalies we like to follow with a scan, or some we may do a serial scan, some may we do a scan towards before delivery in the later half of third trimester to prognosticate, to decide about the mode of delivery, or to the referral centers like patients with CDH, cardiac anomalies, etc. This I've already talked about. So what about the role of third trimester scan for routine anomaly scan? How much are we going to detect if we are going to do a growth scan and look for anomaly? So in this large study, they found that 1 out of 300 women who underwent a third trimester scan for growth, they found a new anomaly which was not detected in the second trimester. So these are areas of debates whether we should be doing or should not be doing, because again it has to be more cost effective and meaningful. As far as growth is concerned, whether you should be doing one routine growth scan for all pregnancies in the third trimester which are low risk is again debatable. Studies have been done, but they have not shown to improve perinatal outcome. On the contrary, they have shown increased risk of induction, preterm births, without any change in perinatal outcome. But if you're doing a growth scan routinely for every woman who is low risk in the third trimester, it's best to do around 36 weeks rather than doing in early pregnancy. Some would say it's good to do a third trimester scan because the woman is reassured everything is good, and there is a bonding psychosocial benefit for both the clinician and the woman, that you're decreasing anxiety. But again, the woman may understand that she may not understand why you're doing a scan when there is no indication. She may think everything is fine, so it is good, nothing will happen to her. Unfortunately, if there is an adverse event during delivery, then she will not understand. She will say, doctor has said your scan was okay, everything was normal, why a problem? So the role of third trimester scan as a routine is still a matter of debate, but we still do one growth scan for all low-risk pregnancies at 36 weeks. But it's always better to always counsel your patients whenever you do whichever scan as to why we are doing the scan, what we are expecting to learn from it, and what we may not see in that scan, we may still miss. So I think it's most appropriate to say one trimester, one scan would be most appropriate. So these are the references, and thank you.
Thank you, Professor Radwal, for your excellent presentation. We all know that among imaging in obstetrics, ultrasound is the most important tool used for managing different aspects of fetal growth and development. Professor Dadwal nicely and elaborately explained with images in all trimesters how ultrasound becomes indispensable in the ideal management of different fetal-maternal issues. In our country, ultrasound is mostly done by our ultrasound specialists. So time has come. I request our fetal-maternal specialist to come forward for the ultrasound. And Professor Radwal also very rightly shows the pathway how our fetal-maternal specialist colleagues will improve their skills in obstetric ultrasound. Professor Firoza Begum, pioneer in fetal-maternal medicine, rightly advised in the pre-congress session that our young fetal-maternal specialists should buy an ultrasound machine. Actually, this will help you to improve your skills in the ultrasound, in the field of ultrasound. There is no alternative for our specialists to improve their skills. Thank you.
Thank you, Professor Dadwal, for your nice and excellent presentation, addressing all the facets of utility, debate, and areas of debate, especially in the third trimester. Thank you very much. Now, I request Dr. Shakil Ahmed for his presentation on Basic of Doppler for Obstetrician as a Decision-Making Tool. Biography of Dr. Shakil. He achieved MBBS from Dhaka Medical College and Fellowship of Royal Obstetrician and New Zealand College of Obstetrics and Gynecology, French coach, and Diploma in Diagnostic Ultrasonography from Australian Society for Ultrasound in Medicine, Master of Medicine, Clinical Epidemiology from University of Sydney in 2015, and certification course in Maternal Fetal Medicine, range course in 2017. He took training from obstetrics and gynecology, started from Dhaka Medical College in 2000, completed training in Liverpool Hospital, Sydney, and obtained fellowship in 2020, started training in maternal fetal medicine since 2011 and obtained subspecialty certification in 2017. His work currently working as a part-time staff specialist in Liverpool Hospital and as the program director of subspecialty MFM in the same unit, also doing some private obstetrics in Liverpool. Welcome, Dr. Shakil Ahmed. I am requesting you to present your paper.
Okay. Can you hear me? Hello?
Yes, sir.
Yes. We can hear you, yes.
Okay, there might be a lag when I talk and when you can hear, but that's fine. Honorable Chairperson, distinguished audience, good afternoon and Assalamu alaikum. I would like to give my heartfelt thanks to Professor Firoza Madam, Dr. Tabassum Parveen, and Professor Maruf Siddiqui, my friend, to giving me this rare opportunity to speak in front of the audience of my own. I was actually planning to come to this conference in person, and I've been preparing for months, but unfortunately, I was diagnosed with COVID just the day before the flight, so I'm in isolation right now. While I was actually watching the video clip, like the Zoom feed, I saw a few familiar faces, so I would like to sort of just say hello to them through here. So Professor Kohinoor Madam, Farna Dewan Apa, Salma Apa, Rashida Apa, Shilu Apa, these people actually helped me a lot in my early days of training, and I just give them my heartfelt thanks. Okay, so my talk is about basics of Doppler for obstetricians as a decision-making tool. It's a pretty big sort of topic to really go on within the next 20 minutes, but I'll try my best. So my presentation has got like 5 components. I start with a little bit of physics of ultrasound and Doppler, and then we talk about a technique of obtaining a Doppler waveform. Then we move on to Doppler measurements of the different Doppler indices that we look at when we see a report. And then we talk about the vessels of interest in obstetrics, which vessels we usually use Doppler on. And the last one would be clinical use of Doppler in obstetrics. So let's start with the physics. I promise you it will be short and not very complicated. So ultrasound, as we know, is a high frequency sound, and it's way above the audible ultrasound frequency. It is basically 2 to 20 megahertz. And it basically is a wave of compression and decompression and travels at a fairly constant speed in soft tissue. We need to be sort of aware of what is frequency. If you see down here, there's these waveforms. So this one, where there's not a lot of waves in this segment, is a low frequency ultrasound, whereas this one would be a high frequency one. So when the ultrasound is passing through the tissue, it strongly reacts with it, and there are 4 major interactions. Some of it gets reflected, some of it gets attenuated, and there is scattering and rarefaction. I won't worry about the scattering rarefaction for the time being. So the transducer is the part which we hold with our hand, which generates the ultrasound beam, and it travels to the tissues. And as the sound wave goes through the tissues, it progressively gets weaker. That's called attenuation. Part of this wave gets reflected back from different tissue interfaces, and the transducer again receives this reflected ultrasound and sends some electric signals to the machine to generate an ultrasound image, is the picture which we see on the screen. So the ultrasound imaging actually doesn't use continuous wave ultrasound. Most of the time it's like short bursts of ultrasound, which is called pulse wave. If you see here in the picture, there's like a little bit of pulse wave here, and then basically the transducer is trying to listen to the reflected wave, and again it does that. So the number of times it sends this pulse per second or per minute is basically the pulse repetition frequency, and it's pretty fast. Now the physics of Doppler. Doppler, as most of us have been reading when we were in year 12 physics, is something to do with the sound wave and moving objects. It's to assess flow or motion. Now, if we have echoes from a moving blood, if we...
Hello, Dr. Shakil, have you slide to show?
It's not showing.
Slide, you have slide?
Yeah, it's not show. You can't see.
We are not seeing your slide.
Oh my God, I'm I'm on the 9th slide. You can't see anything. Okay, just a sec. Just let me see. Oh, maybe.
Please share your screen. Dr. Shakil,
Okay,
please
okay.
share your screen.
Sorry. Just give me a second. What about now? You can see it?
Yes, yes, your slide is saying.
Okay, I better just
thank
quickly.
you, thank you.
I'm so sorry. You guys should have told me earlier. I don't know. Okay. Okay, so, oh, geez, sort of. I'll just quickly. I'm not going to talk. This is just the slides. Never mind. So these are the parts we're going to talk about. Then the physics of ultrasound. The frequency picture of all the waveforms. The ultrasound effects with tissues. And the transducer getting the ultrasound through the tissues, getting back the image, and here's the pulse frequency, and here's the Dopplers. Okay, so the echo, basically how it sort of detects blood flow is the ultrasound gets reflected from the red blood cells. So so basically, if the blood is coming towards the probe, the frequency goes up. If the movement is away from the probe, the frequency goes down. And we get a recording of that. And the Doppler shift is basically the difference between the ultrasound which was sent by the probe and the ultrasound beam which is received. And I wouldn't go into the formula, but it's determined by the speed of the blood flow. So faster it is, there's a bigger shift. And also it's dependent upon the angle between the beam and the vessel. So if you we want to make it as parallel as possible. If you make it perpendicular, you will not detect any flow. So if you want to check the velocity, we try to go as parallel to the vessel as possible. So now let's try to obtain a Doppler waveform. I hope most of us probably have access to an ultrasound machine. So what we need is an ultrasound machine and a patient who's pregnant and happy to have the ultrasound. So we put some gel. This is usually what the panel looks like. And then we move on to the next one. So the buttons which are linked with Dopplers are these 4. So you see the C, PD, M, and PW. C for color, PD for pulse Doppler. M for sort of the motion, M mode, and PW for pulse wave. Okay, so we go next one. So here you go. So this is what we look. If you say C, you'll see something like this. If you look at the blood vessels, this is the umbilical cord. This is power Doppler, where actually it sort of enhances the returning images sort of power. So low flows are better detected on this one. Sorry. And here is the power wave, pulse wave. This is the one which is the most important, where you actually sample as part of the vessel. So if you see this line, it's a little equal sign, which is the gate, which sits on the vessel and then gives you the information. And this is the M mode. I'm not sure, unless you sort of use ultrasound, you probably haven't seen a lot of these. So once you got the waveform, then once you get in the waveform, you can change different settings here. Like you can see here, the baseline, the angle. If there's a bit of angle and you want to see the velocity, you can correct it. There's a PRF we sort of mentioned. I'm not going to go into the details. So once you got the waveform, then you move on to the measurements. So here's a waveform. I've already measured it. But once you sort of got a waveform, you can actually see on the screen, you can choose your vessel, and you can choose either auto trace or manual trace, and that gives you a waveform, and the machine automatically calculates for you. And once you sort of send the data to a software, which is like Viewpoint, it actually will show you all the results will come and you can see, and that's how people report it. So say, for example, an umbilical artery will show all these different parameters, which can be a little bit taxing if you look at it, because there's too many of them. But actually, we don't have to look at all of them. We can actually take a very shortcut and still do very good ultrasound. So when we have a Doppler waveform, so we just have to first check what the waveform looks like. as obstetricians, we don't have to do a lot of different vessels. And most of the time you'll find out that, okay, you already know what the vessel, the waveform will look like. And if it's abnormal, you can just look at the picture and say, oh, something's not right. So for a Doppler waveform, the common things are checking for end-diastolic flow and also characteristics of specific vessels have got. So for example, sometimes the uterine artery can have notching. There is A wave in Ductus Venous. So once you sort of get to see a lot, you'll get a hang of it that, okay, so this is it. And basically when we measure, trying to measure the vascular resistance. So there are different measures out there. So the common ones is the PI, RI, and SD. Now, they're pretty sort of well sort of tested and they kind of perform pretty equal, but PI is probably the one, the pulsatility index is probably the one which is used more over most of the fetal-maternal units I have worked in and I have sort of talked to. And also the next other thing is measuring flow velocity to see how fast the blood is flowing. And that is not important in most vessels apart from the middle cerebral artery. So you don't worry about the peak systolic flow in umbilical artery, it doesn't really matter, but it matters definitely the MCA when you're measuring. So this is basically trying to give you an idea about how they're calculated. Don't need to know the equations, but it's to do with, these are the waveforms. So when the heart contracts, there is systole. So you measure the peak systolic velocity and then the diastole. Machine does it also, we don't have to do anything. And this is a formula it's used to sort of get the idea about what the Doppler like the resistance is like. So now we move on to vessels of interest. So we have got fetal Dopplers and maternal Dopplers. For fetal Dopplers, there are two arteries that are interesting. One is the umbilical artery, the other one is the MCA. For venous Doppler, the Ductus Venosus. And for maternal Doppler, we have got the uterine artery. So these are the four basic ones. There are a lot of other places you can use Dopplers. For somebody who's want to do basic ultrasound or want to learn first, probably these are the ones you have to sort of be familiar first, then to move on to more sort of complex Dopplers. So this is a picture from Langman I had. So basically the fetal circulation and the circulation after birth. So the vessels just here, the umbilical artery, which gets sort of obliterated later on. The middle cerebral is not here, but you can see here on the circle of Willis, this vessel, the middle cerebral. And the next one is the ductus venosus, a vessel connecting the umbilical vein with the inferior vena cava, which later gets fibrosed and goes away. So the umbilical artery is probably the most common and most important one. It arises from the common iliac and it doesn't have any branches until it hits the placenta. So it does mirror the resistance of the placental bed. Now, with the time, as the pregnancy progresses, there's more and more velar structure coming out in the placenta. So the resistance to the umbilical keeps falling down gradually over the pregnancy. And the resistance gradually falls from the fetal end to the placental end. So if you measure the different parts of the umbilical artery, you'll find that there are different sort of PIs. So near the vessel baby, the resistance will be higher compared to near the placenta where it will be the lowest. So again, this is what it looks like when you look at all the numbers, but you just have to do these two things. One is the PI, that number is important. And you can usually see on the side here that it's within the normal range between the 5th and 95th centile. And because there's not much point remembering these numbers because they will change with pregnancy. But if you do a lot of Dopplers, you'll get a hang of this looks like a normal number. And the other one is basically when you see the Doppler waveform, whether you can see the end-diastolic flow. That's important. So that's what just a graph which looks like, and you can see the gradual decline in the resistance. Now the normal resistance umbilical artery blood flow looks like this. You can see there's a systolic flow and there's still pretty good diastolic flow. Even when the heart is not contracting, the blood is moving forward. And next one is basically with more resistance, this diastolic flow keeps going down up to a point when there is absolutely no flow happening when the heart is relaxing. So when there is systole, there is flow, but when there is diastole, there is absolute no. So this is absent end diastolic flow, and you can say it's not good. And the last one is reverse end diastolic flow, basically when you have got very, very high resistance. So when the heart relaxes, there's blood actually running backwards towards the baby, which shouldn't happen. And that's also no good. So clinical use, so there is, when you have a growth restricted baby because of placental insufficiency, you'll have progressive worsening of the umbilical artery blood flow. And that also increases the risk of hypoxia and stillbirth that you all know. So the use of umbilical artery Doppler in these sort of circumstances has been associated with reduction in preterm mortality because we can sort of time when we have to deliver these babies before they actually die. Now, routine use of umbilical artery Doppler in low-risk pregnancies or just general population has not shown to improve neonatal or maternal outcome. So next one we move to is the middle cerebral artery. So this is the larger terminal branch of internal carotid artery in the circle of Willis, the base of the brain. And this one, we actually look for two things. One is for placental insufficiency, there's a brain sparing effect. So when the baby is not getting enough blood, it kind of preferentially shunts its blood to important organs like the brain, heart, adrenal. Now, we can't really measure the blood flow to in the coronary arteries or the adrenal gland of the baby. So, but the middle cerebral artery is easier to measure. So that actually shows that the vessel has dilated, means the resistance is less and there is more flow. So it's the opposite of what a bad umbilical artery looks like. A bad MCA is when the PI is actually low and there's more and more endoscopic flow. That's worrying. The other thing is, as I mentioned before, peak systolic velocity. So the speed of the blood, that's where we measure it. So what happens is if the baby is anemic for whatever reason, the viscosity of blood is less because there's a red blood cell, so it runs easy, it's not thick. So making the blood flow faster, and then the peak systolic velocity goes up. And there are graphs to sort of put them on, and it sort of tells us where the baby is actually moderate or severely anemic. And again, you look at this, a lot of numbers, but you need only two. The PI is the one for that redistribution, whether there is anything happening. PS, the peak systolic, is the blood flow speed, which just tells about baby's anemia. The rest is not really important. We'll probably just touch base with CPR-PI, which is just a ratio later on, but I'm not going to go into any detail. Again, that's the sort of middle cerebral artery look like. The clinical uses, as mentioned before, it's fetal growth restriction, early and late onset, and fetal anemia. Again, you can see on the left, there is high resistance flow, basically, which is normal. So this is what it looks like. But then this one, well, it's probably not the best picture, but you can see this still, the endoscopic flow is a lot more. So there is some sort of redistribution happening here. And when we talk about the speed, this is like the normal speed. So if we go to the top of the thing, it sort of cuts somewhere here, like 55 or something. But here you can see this goes up to 70. So that's like faster blood flow. And if you put in a graph at 35, it probably will be a little bit on the anemic side. Now, the last fetal vessel to discuss is the ductus, which is a small vessel which we saw connects the intra-abdominal umbilical vein with the inferior vena cava. It's very narrow, so there's a lot of aliasing, like a lot of color happening when you put a color on that. And it has an interesting flow pattern. I don't want to go into details, but the important thing is it has no valve. So it's basically directly reflects pressure changes with the right side of the heart. And there's always flow towards the cardiac cycle. It should be never be backflowing that. Flow should be always forwards. So if you see here, there are like three, there's an S wave, there's a D wave, and this opposite one is called the A wave. Usually there is a baseline down here, and there is a bit of gap between the baseline and the bottom of this wave, and that's when we say it's A wave present. When this bit touches the baseline, that's no A wave. When it goes below the baseline, that's a negative A wave. So again, here the important thing is the A wave and the pulsatility index of the vein, and these are the different possibilities with the A wave. It could be present, it could be absent, it could be reversed. And that's the graph. Again, that's like a waveform. Here you can see there's flow here. That's the A wave present. That looks normal. Here the A wave is gone. It's sort of touching the baseline. There might even some reverse a little bit here. But these ones is the opposite way, but you can see these are the Ductus Venous waveform, but there's big, long A waves, which like definitely reverse A waves. That's not good. This baby needs to be delivered soon, otherwise it'll die. So it's helpful in predicting severe fetal compromise in IUGR. So absent, especially early ones. So because usually if you had I'm sure you had a talk about early onset IUGRs and when to deliver. Umbilical artery Doppler not the best thing, because otherwise you'll be sort of ending up delivering a lot of preterm babies when they could stay in the mother's womb for a little longer. And the other thing is in first trimester, Ductus Venous waveform is used in conjunction with other factors to sort of predict risk for aneuploidy. And the last one is the maternal uterine artery. You all know about the anatomy, so I'm not going to go there. And the resistance is usually high when people are not pregnant. But when they're pregnant, because of all the changes in the placenta, the resistance drops and it keeps dropping. Now, usually when you actually have placenta on one side, it's interesting that the resistance on the side of the placenta is a lot lower than the side where the placenta isn't. So again, there's a lot of good flow. You can see lots of end-diastolic flow, which is a good thing here. But here it's tight. So something has happened, changes haven't happened properly in the trophoblast invasion. So and this thing is the thing which is called notching. You see there's a little notch going up. So these are kind of just showing that this is a high resistance uterine flow, increased risk of growth restriction, preeclampsia, that sort of stuff. Now, uterine Doppler waveform reflects the resistance in the circulation from the mother side, but it's kind of predicts preeclampsia growth restriction, but it's not really on its own. It's not really that useful. You use it with other parameters, and then you get the whole picture. All right, and it's at 12 to 14 weeks, the uterine Doppler also helps in screening of preeclampsia. So now coming to the last bit, the clinical uses of Doppler in obstetrics. So usually I just put like 5. So one is, which we already sort of touched base on, the impaired placentation, fetal hypoxia one, where we look at the umbilical, middle cerebral, uterine, ductus, everyone. Fetal anemia, where we look at the MCA, and fetal echocardiography for checking the baby's heart structure and all that.
Dr. Shakil.
Yes, gone again?
Please make it short. We are also in time behind, please.
Okay, we'll be at 2 minutes.
Okay.
Okay, so I'll just rush through this one. So basically, the idea is to deliver or not to deliver. We move on from there, and then basically here you find small babies also, which obviously needs delivery, also appropriately grown babies, but late onset growth restriction. Move on, I'm not gonna go there. And here is fetal anemia for different reasons. Again, you can see here, that's the sort of, for either rectal isoimmunization, infection, fetal-maternal hemorrhage, or TAPS in twins. And basically, you sort of work out whether you need to sort of expectant management, do blood transfusion and delivery, fetal echo, all check, assessment of cardiac chambers, valvular disorders, and fetal arrhythmia. That's on the left. There's an M mode for fetal arrhythmia. Again, depending upon what you have to sort of come up with some measures. Placental disorders like cord anomalies, vasa previa, placenta accreta spectrum, octoriangioma. And again, you look at it and then find out timing and mode of delivery, whether there needs to be interventional radiology involved. And first trimester screening, as discussed. Aneuploidy screening, we took the Ductus Venous and tricuspid. And preeclampsia screening, we looked at the uterine resistance. So that's in short what we probably do with Dopplers day to day. And thank you.
Thank you, Dr. Shakil, for your nice presentation. Actually, it's a very useful device for obstetrician using indexes by assessing uterine artery, umbilical artery, and serial assessment by ductus venosus and different type of indices. We can take decision about the on-time termination of pregnancy to reduce the perinatal mortality and to reduce the need of cesarean section, to reduce the unnecessary induction of labor. So to achieve sustainable development goal by 2030, we should know the use. But our obstetrician need training in these purposes, so we can use this. I am thankful for Maternal and Fetal Medicine Society of Bangladesh for arranging such nice conferences and including these topics in the seminar. And thank you for delivery, for nice presentation. We hope society will arrange training for obstetrician in this aspect so we can achieve our perinatal mortality, reduction of perinatal mortality rate by 2030. Thank you very much, Dr. Shakil.
Thank you.
And all one attending.
Dear audience, now we are close to the end of our session, but before that, there is an announcement. There is an exciting raffle draw organized by Square Pharmaceuticals before lunch. So you are requested to be seated after end of the session. Now I would like to request our Honorable Chairperson, Professor Gulshanara Madam, to give the certificate of appreciation to our speaker, Dr. Vasla Dadwal. I would like to request our Honorable Professor Ferdowsi Islam Lipi Madam to give a newly published book which is written by our respected teacher, Professor Firoza Begum Madam, to Professor Gulshanara Madam. And also requesting Professor Gulshanara Madam to give the book to Professor Firdausi Islam Lipi Madam.
We are thanking our distinguished chairpersons, eminent speakers, participants, audience, and scientific partners for the fruitful completion of the session. So this is the end of the session. Thank you very much for being with us. And we are inviting you to the next session, session 11, the Great Obstetrical Syndromes. Give a big hand and enjoy.
Ladies and gentlemen, and distinguished participants from home and abroad, Assalamu alaikum. A very good day to you all. These are me, Dr. Hasina Begum,
and Dr. Halim Akhtar.
Welcome you all to our 11th session of Second International Scientific Conference organized by Maternal and Fetal Medicine Society of Bangladesh. Today's our session is on the Great Obstetrical Syndromes. The Great Obstetrical Syndromes includes a spectrum of pregnancy complications like Pre-Eclampsia, FGR, abruptio placentae, etc., which are associated with deep placentation disorder. And among them, Pre-Eclampsia is a very common and poses a challenging issue during pregnancy management. So, early detection and both maternal and fetal appropriate monitoring and timely intervention is the cornerstone of the treatment. So, ladies and gentlemen, let us enjoy the session, The Great Obstetrical Syndromes. Thank you.
Dear learned audience, in this session, we are honored to have three renowned gynecologists in our country. Professor Shahin Rahman Chaudhry, Head of the Department of OBGYN, Holy Family Red Crescent Medical College Hospital, and Chairman of IRC RCOG in Bangladesh, and Professor Shahila Jasmine, former Professor of OBGYN, Rajshahi Medical College Hospital, General Secretary of Rajshahi OGSB branch, past President of Rajshahi OGSB, and Professor Afroza Kutubi Madam, Head of the Department of OBGYN, Sir Soliullah Medical College Hospital. We are also have three eminent speakers from abroad. Professor T.P. Baskaran, Andrew Senan, and Dr. Pratima Radhakrishnan. Speakers will be get only 18 minutes for their presentation, and I requesting you to all to complete their presentation within time because we are such in a hurry. Next session is our lunch. As Dr. Andrew Senan is not able to hear bodily, he conduct his session in Zoom link. Now, I requesting you, the chairpersons, to conduct the session. Madam, please come on dais and take the session.
Can we start? Shall we start? Okay, ladies and gentlemen, very good afternoon. We are going to start a very important session, as already mentioned, the Great Obstetrical Syndrome. We have 3 speakers. They are renowned and coming from abroad. I think the one is going to talk about in virtually. So among these 3 speakers, we have the first speaker with us is Dr. T.P. Bhaskaran. I'd just like to introduce you Dr. T.K. Bhaskaran. He is the Medical Director, Fetal Scan Center, Kuala Lumpur. He is the Honorary Lecturer, Pardana University, Kuala Lumpur. And he was previously posted as a Head Maternal Fetal Medicine Unit, Kuala Lumpur, and also President, Malaysian Society for Ultrasound and Medicine. He's going to talk about a very time-demanding topic, that is pre-eclampsia, then approach, challenging, and care. May I request Dr. T.P. Bhaskaran to present his.
Kind words of introduction. Good afternoon, ladies and gentlemen. First and foremost, I'd like to thank Professor Firoza Begum and the organizing committee for having invited me to share some thoughts with regards to pre-eclampsia. And also congratulations to Professor on her launch of her book. Now, pre-eclampsia, in the next 20 minutes, if I'm going to look at pre-eclampsia approach, challenges, and care, is going to be really a challenge. Now, first and foremost, we need to recognize pre-eclampsia as a nightmare to any obstetrician, simply because the onset is unpredictable, and in spite of good management, often the outcome is unpredictable as well. But we need to recognize that it's important to an obstetrician simply because it contributes significantly to maternal mortality. Of the 500,000 pregnant women who will lose their life in every year, 1/3 of them may actually be responsible. The responsibility may be related to hypertensive disorder in pregnancy. Now, if you look at the global data, it still suggests that if you take off indirect causes of maternal mortality, it probably sits next to postpartum hemorrhage. Now, quickly looking at approach, I presume the approach and the care part is probably similar to what you actually practice, and probably we'll focus a little bit more on the challenge. Now, we need to recognize that I'll be talking in terms of low resource centers rather than similar to what we face in our own country. But I think after post-COVID infection, I think most countries in the developing countries are in the low resource centers. Now, most often the diagnosis is made the antenatal period when the patient comes for the first time for an antenatal assessment. And we have blood pressure measurement as a routine measurement during antenatal assessment, and that may be the point in time when we'll actually find out that the patient has got high blood pressure. But we have to keep that in mind, the background, that it is related to the physiological changes where blood pressure will actually be low in the first trimester and towards the second trimester. And so we may actually miss out those patients who actually have chronic hypertension who present in the clinic. I think this slide probably summarizes what we actually want to know in terms of hypertension in pregnancy. Diagnosis is made based on the readings of 140 and 90 and above. And if she is pregnant, then you want to slot her into 2 different groups. One is the chronic hypertension, who is diagnosed of this condition 20 weeks before the 20th week of her pregnancy. And the other is when she presents after 20 weeks and this diagnosis is made. And then you categorize them into 3 groups. Those with the proteinuria would fall into the gestational hypertension. And when they actually progress on to have proteinuria, then they'll end up with pre-eclampsia, and the worst case scenario being eclampsia. We have to keep in back of mind that if we are seeing this patient in the first 20 weeks, then it may actually be chronic hypertension, may be masked during the first trimester of pregnancy simply because of the physiological changes taking place. But then nowadays we don't use the term hypertension in pregnancy simply because a lot of classifications come about with regards to pregnancy-induced hypertension, and the current classification has actually shifted to looking at these 4 components. One of the main difference between this and the previous classification is that pre-eclampsia doesn't actually form a certain group. It falls into the spectrum of the pre-eclampsia group. But I think in practice at the ground level, I think this slide actually sort of puts the problem in its right perspective. Now, we go on to define pre-eclampsia. In our clinical practice, we often start recognizing the patient comes in with edema, and then you go on to find out that she actually has got hypertension, and we do a urine test, there is proteinuria. But we need to recognize edema itself is an unreliable sign simply because 80% of pregnant women may actually have pedal edema. and so that might not be very useful. So the indicator still is hypertension, but we also need to recognize in our own practice the spacing in the first trimester and the second trimester of antenatal visits will be significantly longer compared to the third trimester, and so we may not be able to catch the problem of hypertension as early as possible when we actually manage this only at the clinic level. Now, redefining based on the current classification, we need to recognize proteinuria need not be a component of diagnosis of preeclampsia. But we also recognize the non-invasive testing in terms of using ultrasound allows you to pick out patients much earlier, simply because if you're looking for organ damage, then certainly you need to run some blood tests, and that may not be available at the point when you actually perform or assess this patient. But certainly an ultrasound will probably be available in the antenatal clinic. Now, moving on from the presentation to the pathophysiology of preeclampsia, let's just recognize that significant proportion of the theories will indicate that it's a placental disorder. And this is divided into two stages, one in terms of impaired remodeling of the spiral vessels, and the other is the effect of that happening later on in pregnancy. If you look at this diagram, it actually represents what happens in a non-pregnant state when there is high resistance, and in a normal pregnancy, because of remodeling of the vessels, there will be low resistance. But when there is preeclampsia, then the resistance becomes increased. And however, we don't know whether it is an effect or cost of the problem. Now, if you look at this slide, it actually looks at the stage 1 where it is related to poor presentation. A lot of high-tech markers or predictors are actually based on the first trimester scan, looking at the uterine artery and looking at various biomarkers and trying to actually predict the patient who is at high risk for preeclampsia. But in reality, we always catch the patient in the second stage when inflammation has taken place and the patient actually makes a clinical presentation. So we probably have missed the boat, and probably we need to recognize the management is probably going to salvage the patient at this point in time. So going back to a low resource center, I think we need to recognize we have to focus on less tech, high-tech biomarkers, such as looking at risk factors. Now, this slide actually divides the problem to 3 different aspects in terms of immunological related, disease related, and maternal related. We need to recognize this need not actually apply in the first trimester of the pregnancy, because some of the components in these factors actually can be picked out in the pre-pregnancy state. So here's a case where we need to sell in terms of reducing maternal mortality should start not during pregnancy, but in the pre-pregnancy state. Of course, preeclampsia will have its complications in all systems. And here is a list of complications on the left side showing where the maternal presentation may represent any sort of organ damage, whether be it in the brain, in the liver and kidney and so forth. But here's a point to remember on this slide is that just because, for instance, if the patient comes with seizure and she's pregnant doesn't mean she is eclamptic. She may actually have a lesion in the brain. So one must think out of the box when we are managing a pregnant woman, not just focusing and trying to fit the diagnosis according to the clinic where we are standing. Now, on the other hand, if you look at the fetal problem, now the fetus often talks to us by way of, in many ways, and the ultrasound actually allows us to see that the baby is actually been affected by the eclamptic state or the preeclampsia state. In terms of uteroplacental insufficiency, you'll see growth restriction which may require you to make the decision in terms of delivery. However, placental absorption and stillbirth may not always be avoided. Now, if you look at the classification of hypertension disorders, you can, of course, classify at the clinical level in terms of mild, where you may actually allow her to still be managed as an outpatient. When it's severe, then certainly this patient needs inpatient management. The whole list of criteria to be looked at in terms of maternal, fetal, and so forth, but we need to recognize the problem is severe preeclampsia, and the point which we need to take the patient to is delivery, because we know delivery is the only management for this condition. Now, of course, it's no-brainer if the patient actually comes at 20 or 22 weeks and when there is significant hypertension, that you should consider delivering. Then again, think out of the box. You don't want to deliver the baby and then find out that the hypertension is not settled simply because she had a tumor in the adrenal gland. So we need to think beyond just looking at pregnancy-induced hypertension or pregnancy-related hypertension. On the other hand, if it's towards the 38th week, then obviously delivery would be the optimal decision to be made. The problem often the obstetrician faces is between the 28 and 32 weeks or even 34 weeks, depending on the kind of setting you're actually working in. Here, every day makes a difference with regards to survival of the baby and better outcome for the baby. But we need to recognize the primary problem is pre-eclampsia, and that you have to salvage the baby, salvage the mother rather than focus on the baby. Of course, as a human being, we would like to save both of them, but we must know our priorities. At the end of the day, we need to recognize if you don't have a canvas, you can't do a painting. Next, we move on to the care of the patient. Care of the patient, in most of our instances in low resource setting, starts in the antenatal period after the patient is pregnant, diagnosis made at that point in time. Of course, if you have a mild pre-eclampsia, you might still offer her outpatient management. But once it shifts to severe pre-eclampsia, then you know medications have to come in. Now, even if you allow her to go back or be as outpatient management, we have a whole lot of medications which can be used to reduce the blood pressure. But it's best for you to use a drug which you are familiar. But you must remember the antihypertensives which are used are not protecting the baby, but merely protecting a mother from reducing a risk of stroke. So the reduction of risk of development PE or abrupt show or better improvement outcome is not going to be dependent on the antihypertensives which actually use. Now, of course, when it comes to severe, then there are some action pointers. That means for you to decide that you have to make a decision at that point in time. The action which is actually warranted by you is just the delivery of the baby. So the pointers are deteriorating of maternal condition obviously requires you to make a decision in terms of delivery. Mature fetus and premature fetuses will come in the decision-making policy, but we need to identify who requires the immediate delivery and who can afford to have some sort of supportive treatment in terms of either antenatal steroids or magnesium sulfate cerebral protection to afford or to allow the baby to actually have a better outcome. But remember again, you need to focus on the mother. So before you consider delivery, you certainly want to stabilize the condition itself, because rushing into OT trying to deliver the baby may not sometimes be the optimal decision. You need to have a patient which is stable before you go on, and IV antihypertensive drugs will come in handy. Again, use only the drugs which you are familiar with. Now, anticonvulsant drugs certainly has an important role when you're actually managing any sort of patient with severe preeclampsia, but also those patients who actually are planning to deliver in the 28 to 32 weeks, who also have the added benefit in terms of cerebral protection for the baby, sorry. And in terms of management, there's a whole list of things which you'll monitor probably, but at the end of the day, all this actually points out to the plan for delivery. So again, you need to follow your local guidelines with regards to this. Here, at the end of the day, we need to recognize the problem doesn't stop at the time when you actually deliver the baby, but it progresses on to the postpartum period. Here are some of the indications which will actually guide you in terms of making a decision with regards to delivery. And these indications will also dictate the mode of delivery. Doesn't mean that you have to consider a cesarean section in all instances. Now, the management of this patient need to continue on the postpartum period as well, simply because we recognize that these patients may have a critical period after they have delivered the babies. And it's also need to recognize that those patients who actually suffer preeclampsia in their pregnancy also have significant residual impact in terms of cardiovascular disease and hypertension later on in their life, and that must be addressed as well. Now the challenge comes, and I think this is the place where we probably need to think out of the box to see how we can actually reduce the maternal mortalities associated with preeclampsia. Now, if I can reflect back on the situation back home in Malaysia, we recognize that it still remains one of the main causes for maternal mortality, even though we have improved over the years in terms of reducing maternal mortality, but the hypertensive disorders still remain in the list right now at the 4th level. Now, I can see that we are in a similar situation in Bangladesh as well, and it's good to know that the maternal mortality rates have actually significantly reduced in the last 10 years. But again, you can see in the data actually suggests that preeclampsia, I presume this eclampsia actually includes all the hypertensive disorders, also still remains in the top of one of the reason for maternal mortality. When we looked at our own cases where we lost because of hypertensive disorders, we found that some of the reasons which actually caused these losses were, one, failure to recognize the severity of the disease at the time of presentation and not making the right decision at that point in time. And the lack of understanding on the patient's level also contributed significantly in terms of poor outcome. And the lack of understanding in the community level also becomes very important, because people often relate hypertension to their grandparents who actually have hypertension as well. It's just not a big deal. And also we found that in some instances there were inadequate understanding at the healthcare giver as well. Now, I think one of the things which is glaring in this is that poor awareness in terms of the importance of this condition in the pregnancy. And very often, I think, I'm sure in a large country such as Bangladesh, logistics may also play an important role. Then again, culturally, I think in Asian society, we often sometimes misplace the clinical priorities in terms of attempting to save the baby at the cost of losing the mother. Now, if you look at the provision of health services, most instances we have actually worked on tertiary hospitals, secondary hospitals, supported by MCH clinics and so forth. We have a very good system back home. We have almost about 900 maternal and child health clinic centers and private facilities all over the country. It is said that if you stand in Malaysia anywhere and you are actually only within 5 kilometers from any sort of medical facility, you only know which direction to actually walk in. But the fact is that the government can only do that much in terms of bringing the infrastructure to the patient. But I think, and it actually is plateauing the maternal mortality rates. I think we need to recognize we have to think out of the box. There must be a paradigm shift, and COVID actually showed us that we should actually have been a paradigm shift, because there's so much of digital disruption which is going on, and we recognize now we can actually think out of the box and try to use what has happened in the last 3 years in terms of virtual platform and digital devices being held by all people out there. And that can actually make a change in terms of reducing the maternal mortality. So I think it's time for us to actually reverse the direction in which we should be managing these patients. It's time to empower the patient. I think if the patient knows that she is at risk of dying, then she'll be much more motivated to actually seek for medical services. So again, we need to go back to the pre-pregnancy assessment. In my country, we actually focus on actually establishing pre-pregnancy clinics to assess patients before they actually embark on a pregnancy. But I put it to you, probably its time has come for the patient to actually be empowered, and she has to decide whether she has optimized herself. So self-assessment in terms of just using a check system may actually allow her to consider recording her blood pressure before she gets pregnant, or lose her weight, and we know BMI actually significantly causes or increases the risk of pre-eclampsia. Now, when the patient actually ends up in the first trimester, a dating scan becomes very important. I think that should be mandatory. The power of the ultrasound machine is not in detecting anomalous fetus in the 3% of the population, but the power can be applied in terms of dating the pregnancy and monitoring growth patterns. That's why you're going to actually make a difference in salvaging the patient. And I think the tool is going to remain in our antenatal clinic. We need to recognize we are in an obstetric practice right now where it is image driven. So we need to actually not confine the use of this machine at the level of the doctor, but actually bring it down to the midwife. So clinical risk scoring takes place in the first trimester, and we need to focus on, there is a whole list of it, of course. If you actually find that they actually fall in the high risk, then maybe it's time for you to actually use some simple tools such as using aspirin, which actually has shown to be effectively reduce pre-eclampsia, reduction in preterm labor and IUGR as well. So we need to capture then in the early part of the pregnancy, the first trimester, before she actually presents with the inflammatory issues of inflammation which has taken place as a result of placental disease. So if you actually start her on low-dose aspirin as early as 16th week, we know that makes a great difference. And back home in Malaysia, we actually use it from as early as 14 weeks. So all you need to recognize here, the prevalence of preeclampsia in the high-risk group is significant, and perhaps there will come a time in which we need to actually just start all primates on this. Now, WHO also shown that the use of calcium actually become important in terms of reducing the preeclampsia effect as well. Now, again, when we offer medication to the public, I think we need to make them understand that this is not a medication, but a supplementation. Because when you say supplementation, then it's taken up by patients at all levels. Now, having identified these people, we need to actually keep them on a check system in terms of self-assessment. If the patient can be motivated to do self-assessment, it takes away the time frame of 4 to 6 weeks when she may actually have a next visit at the clinic. A simple tool is having a digital manometer, which is very affordable at this point in time. And for those who actually say that, oh no, the digital BP machines made costly, maybe we must give some thoughts to our cultural issues. For instance, perhaps the next time you attend a wedding, you should be gifting them with a BP meter or glucometer, and that may go a long way in terms of reducing preeclampsia. So when it comes to, not only you want to empower the patient, but you also want to empower the immediate caregiver, that is the midwife. If a midwife can actually be trained to do a basic ultrasound in terms of looking at biometry and uterine artery, looking at the diastolic notch and so forth, this can be easily trained. The rule we actually apply in Malaysia is that whenever we want to teach them something, we say if a nurse can drive a car, then certainly she can actually use these machines to gain some information. And in terms of cost, I think in the near future we'll recognize that the ultrasound machines are going to be handheld and it's going to be very, very affordable, and that's going to change the scenario. And perhaps the training of using the ultrasound machine must start now in readiness when the machines become very affordable and will be made widely available. Now, also while you have identified these patients, they must be followed up by expectant management in the routine MCHC. So a dating scan can be done in less than 5 minutes if the proper training has been provided to a midwife. And now the empowerment of the midwife must include the training of ultrasound, and she must also be able to administer some drugs at the periphery level. And this we have actually initiated in our own country, and probably we have down-regulated in terms of identifying which drug can be actually used by the nursing staff or the midwives. And COVID has taught us that virtual platform monitoring may be something which is very, very affordable and can be done. And in a large country where logistics becomes important, if you identify the risk factors early on, relocating these high-risk pregnancies closer to the facility may be a thing to be considered. And in a large country, we often have relatives all over the place, right? So sometimes it's important to get the patient to a relative's house who may be near a tertiary level facility. In terms of cultural setting, we all recognize sometimes the patient, especially the primary, has got high-tech management in a tertiary level center, but at the time of delivery, she ends up in the village and delivered where facilities are not available. Now we need to recognize in terms of reversing this entire scenario and relocating them, identifying that they are high risk and that they should be actually close to a tertiary level facility. So tools of empowerment are actually very, very simple, some of which already exist, okay? One, we need to create awareness. The awareness is very, very important, and I was very impressed with the previous lecture where Dr. Chowdhury actually spoke on the ROP. I think it is such an important lecture. I think we need to take that message back because awareness is so poor. And I think in pre-eclampsia as well, the awareness needs to be created. Awareness not among the doctors, but awareness among the patients that they can make a difference in terms of identifying the problem and ensuring that they don't actually die during the pregnancy. Now, if you took, for instance, how difficult it is to get this information across. I'm sure the passing away of Queen Elizabeth 2 days ago went out to 3 billion people in like 20 seconds because of social media. Half the world knew that she actually passed away in just probably a couple of seconds. So we probably need to use the social media in terms of, in a very proactive manner in terms of creating awareness of these conditions to the patient. Self-health checkup, I think, is very important because we know a simple thing like monitoring the blood pressure on her at home rather than once in 4 to 6 weeks in the antenatal clinic, in an overcrowded clinic, becomes very important. And if she can actually keep a good record of that and present that at her clinical visit, that may make a difference in terms of in identifying the patient at high risk. Then again, we need to empower the midwife, as I said, in terms of ultrasound skill, and with the availability of virtual platform monitoring, she can create a group in terms of communicating with these people. And this communication should not include just the patient, but also family members. I think we often recognize in the Asian setting, very often there is a maternal fetal medicine specialist in each family who often actually may be counseling against what we are actually informing. So we found that in our country that we often get the midwife to speak to one of the senior relatives in the family, and she becomes the partner in health management of the pregnant women in that setting. And in a rural setting, what we have done is we actually allow the midwife in that area to recognize, even if there was no ambulance service, to identify who has got transport, who may be willing to take a patient at a short notice in their setting to a hospital. So while we wait for the game changer in terms of an ideal predictor for pre-eclampsia, we need to recognize we need to continue monitoring the placental changes in a placental disease, because the disease process is not going to change. The placenta will continue to misbehave and the delivery will be needed, and timing of the delivery will be decided by the health caregiver based on the risk factor. So in conclusion, we need to recognize that pre-eclampsia is a serious complication during pregnancy, simply because it not only increases maternal mortality, but also we are forgetting there's going to be significant maternal morbidity of the survivors, not only after the pregnancy, but well into the rest of their life. So early detection and appropriate management, bin delivery, is the key to satisfactory outcome for the mother. So empowering the patient and her immediate healthcare provider is probably the game changer for this point in time, because we need to recognize if we keep doing the same thing, please do not expect different results. Isn't it? Thank you very much.
Thank you, Dr. Bhaskaran, for your excellent presentation. We obstetricians are very familiar with the problem you have discussed. We understand the background of the problem. We are managing the complications. But one of the things you have highlighted today is the primary approach and the patient's empowerment, which is really encouraging for us to understand, and I think we are doing as well. In terms of this primary approach, you did discuss about the patient's awareness about the symptoms. Sometimes not only patients, is the caregiver should understand, because sometimes it can be mislead with a low sort of clinical problems. And one of the things you have highlighted about the monitoring of the blood pressure at home. We know the electronic monitoring are available in even Bangladesh as well. And not only the monitoring, as the COVID has actually moved us to communicating with the mobile. So the patients can actually communicate with the caregiver about knowing their blood pressure. So in that way, actually, we can pick up the red flags. So well ahead, before establishing this problem, we can actually pick up the high-risk group. So which is very wonderful. And also, you have also highlighted about the approach of direct approach with the midwives. Though in our country, probably the juniors doctors are still in the lead, and doing this fetal biometry to adjust the timing and monitoring the mother. Thank you once again for your excellent presentation. Thank you. May I now request Professor Shaila Jasmine to introduce the next speaker. Thank you.
Thank you very much.
Thank you. Very good afternoon. First of all, I want to give my gratitude and thanks to all, from my core of heart, to all delegates, all teachers from home and abroad, to enrich us through this seminar by daily to daily practice and update knowledge in this seminar organized by Fetal Medicine Society of Bangladesh. And I also give my thanks to Professor Firoza Begum Madam. Then I want to introduce my second speaker of this session, Professor Andrew H. Chenan. He is Professor of Obstetrics at King's College London, based at St. Thomas Hospital, Clinical Director, South London Clinical Research Network, Chairman APEC, Action on Pre-Eclampsia UK Charity, Cairo Figured Preterm Committee, and leads on NIHR Global Health Research Group to reduce maternal mortality and build capacity in low-income countries. And most probably, sir will join us with Zoom. Sir, I am requesting you to start your presentation.
Hi there, everyone. I'm Professor Andrew Chenan from London. I'm absolutely delighted you invited me to give a talk. So I've managed to pre-record this because I'm traveling at the moment, but I've been asked to talk about managing preeclampsia in challenging settings. So today I'm going to go through a number of areas that are slightly more contentious or new, talk about prediction, prevention, issues around detection, but also treatment and management, which I think is important in this condition. We all know preeclampsia was related to placental disease. Remove the placenta, the woman will get better, not immediately, but that is the definitive cure. And I won't go into the detailed pathophysiology as we understand more about it. But the thing about preeclampsia is, as it originates very early on in the pregnancy, the actual pathophysiology and various parameters do alter before the clinical features present. Eventually, one gets high blood pressure and proteinuria, which are the key hallmark signs. Not always with preeclampsia, but it's relied upon to tell us who we need to worry about. Some people will get symptoms, quite a few, but not all. And I think importantly, there is a crisis that invariably happens if you have the diagnosis right. That is life-threatening, either to mother or baby. And the idea is we deliver the mother in a timely manner before that crisis happens. And this is very rarely more than 2 weeks. And if it happens in preterm preeclampsia, it's often over only a day or two. So for a lot of preeclampsia, actually, there are no symptoms. We can now measure things earlier on in the pregnancy that tell us preeclampsia is coming. And these are new tests which are only just recently been introduced, and I'll talk a little bit about those, the angiogenic markers, what we call PLGF, placental growth factor-like tests. So the poor placentation happens early, but there really is kind of no signs or symptoms until quite late on. So can we predict the disease? Well, yes, we can. There are clinical features. There are tests. One very important point about preeclampsia is if you look at the low prevalence of the condition, it means that if you have a very good test, it still gets it wrong a lot of the time. In other words, we have quite a lot of false positives. That's just a simple statistical quirk of having a low prevalence condition. So what does that mean in practice? Well, let's take something we all know about. So being overweight or having a high body mass index is a risk factor for preeclampsia. It actually triples your risk of getting preeclampsia, a threefold increased risk. But actually in practice, most people who get preeclampsia are not obese. And if you are obese, you're not likely to get preeclampsia. So you can see there is huge overlap because of it being a low prevalence condition. So what that tells us is doing extra tests to tell us who to worry about has some potential. And there are some slightly unusual risk factors. Recently, we published this short case report showing that donor eggs are a very potent risk factor because of the immunology of having sort of foreign material that kind of predisposes to it. And sometimes a clinician needs to know what the risk factors are. And I think around the world now, as assisted conception rates are escalating, it's very important to know that donor eggs are a potent risk of preeclampsia. Now, we know, when I was talking earlier about the angiogenic markers, just to kind of give you some insight into this, soluble FLIT is the classic one being measured now that increases, and PLGF reduces. And there's a big literature on this. We know from these studies that right from the first trimester, PLGF here is lower in those women destined to get preeclampsia. And once you have preeclampsia, the levels are very low. And the opposite for soluble FLIT. And some companies will do a ratio of the two, and others will just measure PLGF. Now, let's move on to prevention. Low-dose aspirin is a very simple, safe treatment. Our guidelines now recommend giving low-dose aspirin. There's a list of people with risk factors who should get it. So 75 milligrams is recommended as a routine if you have a high risk factor, such as underlying hypertension or chronic renal disease. But also if you have a couple of not so high risk factors, such as being slightly older, having a high BMI, or even twins, if you have two of these risk factors, we would recommend giving low-dose aspirin from early on in pregnancy. However, there's increasing evidence in this area. We know, for example, that when you give the aspirin, it might matter. Those people who got aspirin at night seem to have a better treatment effect. And so such a simple thing to do. We do recommend giving aspirin at night. We're not entirely sure of the mechanism. We also know that if you give a slightly bigger dose, it probably has a better treatment effect. So obviously 75 milligrams is established and is safe, but we know giving more than 75 milligrams, so some parts of the world that's 100, sometimes it's 150. Certainly if you have a woman who's overweight, that seems to be a sensible thing to do from a pharmacological perspective, but also if she's particularly high risk, it's probably justified given the safety. So I will give 150 milligrams to people who are overweight or have had previous failed aspirin and so on. The previous literature said aspirin does good things to you. It not only reduces preeclampsia, but it also stops delivering early, baby dying, and so on and so forth. And the problem with the literature was it just wasn't in the right populations. But again, if you give aspirin in the right way, it probably has a better treatment effect. This meta-analysis suggested about a 10% reduction in everything, but the MFM group in London under Kypros Nicolaides has kind of done a lot of research in this area. Leona Poon published this showing that aspirin might do better at 150 if you give it from 12 weeks, stop at 36 weeks to avoid the side effects, give it at night, and use a targeted regime of tests to tell us who should get it, including blood pressure and antigenic markers. And when you do that, and you actually get a reduction in preeclampsia that's much greater. So for early onset preeclampsia, which is what we're most worried about, there's nearly a 90% reduction. So being clever with aspirin, giving it to the right people. Now, obviously, whether you have the resources to do tests to target it, it depends on which part of the world you're in, but even simple history or simple blood pressure tests are a way to go. What about detecting preeclampsia? We know that blood pressure is obviously the hallmark of diagnosis and management, but it is very variable. So you take someone's blood pressure, even a minute or two later under controlled conditions, it will vary a lot and it will go up and down. And therefore we do things like repeated measures or getting people back before we make a sort of diagnosis of hypertension. We also know there are difficulties with blood pressure machines, so automated devices that work in a different way. They don't listen to the sounds, they actually look at the vibrations of the cuff, the oscillations, and they also underread in women who have preeclampsia. So we've got to be a little bit cautious when we're using these automated devices in clinical practice. Preeclampsia is associated with changes in your hemodynamics and vasculature. So there are changes in your cardiac output, large changes in peripheral vascular resistance, and there may be swelling in the tissues. Basically, all these changes mean that these automated devices don't work as well. Here's an example of one where you have a relatively expensive machine on the right there that is actually giving a diastolic of 66 in a woman who's just had an eclamptic fit, whereas the machine on the left, which is a cradle VSA, which I'll talk to you a little bit about later, we know is a validated, accurate machine in preeclampsia, and it's giving a very different reading and indicating with an amber light that this woman is hypertensive. A diastolic is nearly 20 millimeters higher, taken at the same time on the same patient. And this 20 millimeter difference is often a problem with these automated devices. And it might matter. So here is an example of the same machine being used in Sierra Leone with an extremely high blood pressure, whereas a fairly sophisticated ITU machine is giving a blood pressure of 160, 112, whereas the validated machine is giving a blood pressure of 210, 137. And everyone was thinking, oh, well, the cheap-looking machine on the left isn't giving an accurate reading. It turns out that this woman went blind a couple of hours later, and I suspect she did have very severe hypertension. The lesson is you should use automated devices that have been properly assessed for use in women with preeclampsia. There's also challenges with proteinuria, dipstick assessment. We know that dilution of the urine, and other errors can mean that we get it wrong. So here's an example of just one patient who has dipsticks across a 24-hour period. Depending on when in the day it is done, it ranges from trace to 2 pluses, and therefore you can get false negatives. When she actually gets a 24-hour collection, you see she does have significant proteinuria. And there are ways around this. We now do creatinine protein ratios. There are even dipsticks that can do ratios that are available, and these are recommended by NICE as a way to get around this problem. Obviously, these things cost money. In many parts of the world, there aren't even urinary dipsticks to check. So it's important to get it right when you do have them. What about symptoms of preeclampsia? We know that preeclampsia is associated with certain symptoms. Classically, severe headache, maybe blurred vision, floaters, things around the eyes. You might get epigastric pain, particularly over the liver. Vomiting and swelling are the classical symptoms. Now, we all know that pregnancy can cause any of these symptoms as well, so they can be confusing. But it has now been recommended by our governing bodies that we do tell every woman about these symptoms, so at least she can seek attention should you have them, if they're more persistent and unusual. And at the very least you can do is go and have a blood pressure check, and that can rule out whether the symptom is just physiological or is related to a disease process. Now, I'm going to talk a little bit about the angiogenic markers. This is a Rop curve. Don't worry about the details, but essentially it's showing that if you have a level of over 100, it reliably tells you that a patient is not going to deliver from preeclampsia. The women who are tested in this study were those who walk in with a bit of hypertension or some other symptom that you think, could this be preeclampsia, but we don't know yet. Let's do a blood test to find out if it genuinely is. And these angiogenic markers, in this case, PLGF, is very reliable at telling us, is she going to be okay for some weeks, months, or is she going to have a crisis in the coming days that needs attention? And in the woman who had a level under 12, you can see this very reliably told us this woman was going to need delivery from preeclampsia within a couple of weeks. If you look at this in a slightly different way, you can see on the red lines that it doesn't matter whether you had atypical preeclampsia or superimposed preeclampsia. If you had an abnormal blood test, the time to delivery was literally only a few days, or often about a week or so. Conversely, if you had a normal level, in the green lines, you went some months before needing delivery on average, and basically it was telling you that you are normal. Again, you can see when you compare PLGF to all the things we used to do, like or what we do about assessing blood pressure, like hypertension, uric acid, and ALT, it's a much better test to tell us whether you have a genuine disease or not. So it's not really a test to check is your body being affected by preeclampsia. It's a much more upstream test telling you, is preeclampsia coming? And the question is, how do we use this? Well, in our studies, we've shown that about 1 in 4 women who walk in the door with suspected disease will have a very abnormal level, and on average, they need delivery 9 days later, and therefore we can consider admission to hospital and treat them as if they have preeclampsia. But also, if they're normal, which is about 40% of the women, because they go a couple of months before any problem, essentially they can go back to normal antenatal care. So we have a test that's very reliable. Now, these are new tests, and I'm sure you won't be familiar with them, but just to say there are 2 or 3 now on the market being used. But we are looking at bringing these into a low-income setting. There are now new tests, such as this one, which is a simple point-of-care finger prick. And here it is being used in Sierra Leone. And I think it won't be long before we'll be able to use these tests in the most challenging parts of the world where most of the disease is. And of course, 95% of the deaths, or even more, from preeclampsia occur in, Africa, Asia, and the more challenging parts of the world. And this is where we really want to have these new investigations. If you're interested in reading a bit more, Alice Hurrell, one of our PhD students, has written this very nice review, and essentially it shows you all the different tests and how it rules in and rules out whether you genuinely have preeclampsia. We have incorporated the tests into our guidelines. This is the NICE guidelines, and essentially it upgrades or downgrades the recommended management. Importantly, when we actually use this in clinical practice in a clinical trial, it actually resulted in us diagnosing preeclampsia earlier on average, and even in the context of UK management, we improved outcomes. So we think it's a good test, and it's now been recommended to be rolled out in the NHS. And you can see here how in those women who we saw the result, we were able to make the adverse outcomes better. So you can use angiogenic markers beginning of pregnancy to detect who should get aspirin. Obviously that's costly, but it is something that is done in many countries now, and FIGO recommends this as part of a number of other tests like blood pressure measurement and scanning, but tell you, are you going to get preeclampsia? And you can target aspirin. However, the commonest place to use it, and this is where it's now recommended in the UK, is those people, the many people who come in and you're not sure whether you need to admit them and do lots of tests or whether they're going to be okay. And this really is why it's been shown to be very cost effective. Once you have preeclampsia, these tests aren't that useful. If you're a good clinician and you diagnose it well, they're all abnormal, therefore it doesn't add that much value. But in a challenging environment where you don't have good diagnostics, where you may not have dipsticks, it's possible that it's a really good, simple way of confirming whether you have a woman who's going to run into trouble. And if we can get a cost-effective test in that situation, that might be a very good new thing. Now, I'm going to go on and talk about the management of preeclampsia in terms of treatments and the definitive management, which of course is delivery. We have had great success in the United Kingdom in terms of reducing morbidity, mortality in this case, in preeclampsia. For many years, preeclampsia was always listed as the top 3 cause of death. Suddenly, in the last decade or two, it's gone down to the least represented cause of death. So much so that only 1 in a million women now are dying from preeclampsia in the UK. And it's not because we have sort of discovered some magic bullet that helps prevent it. Aspirin probably has helped to a degree, but certainly not entirely. But what we do is we manage it well. We have universal healthcare provision. Everybody gets screened with blood pressure, and it turns into obviously translates into good outcomes. So you can see here from this publication done by one of our fellows how preeclampsia really came down a lot in the 1950s because of improved healthcare provision, but more recently it has dropped again. And you know, the real challenge for us is out here in Africa and Asia, and this is a sort of WHO infographic demonstrating how preeclampsia, when kind of put into geography, is really represented principally in Africa and Asia. And our challenge really is how are we going to translate the successes from those parts of the world that have good management into these parts where we really can make a big difference. So we look back at our UK experience, and interestingly, when you look at the drugs and the medications that are introduced into clinical practice that we all know and love about managing preeclampsia, which I'll talk about, high blood pressure management with antihypertensives, anticonvulsant therapy with magnesium sulfate, they themselves, when they were introduced, didn't have a big impact on the overall mortality rates. And it was probably the earlier managements when we were getting our, regular antenatal checks, blood pressure measurements, general health advice, obviously had the biggest impact on reducing mortality, and this, I think, is an important principle moving forward. Why it suddenly got better again more recently is probably related to just doing it all a bit better, giving low-dose aspirin, control preeclampsia who are indoors with indoor cooking are subjected to this pollution that somehow changes their threshold of having eclampsia. And I think there's a lot of research to be done still. I'm sorry I'm not with you to be able to answer questions, but I hope you enjoy the rest of your conference.
Sorry.
Thank you very much.
Due to shortage of time, we have to stop the lecture of Professor Andrew. But in this time, we understand that preeclampsia is the leading cause of maternal mortality and early birth, which is also associated with considerable morbidity worldwide. Relatively simple, cost-effective strategies and can reduce this impact if we understand the pathophysiology of preeclampsia properly and proper monitoring, timely intervention, and timely referral to proper center. We can understood very nicely from the lecture of Professor Andrew. And this can also reduce if we simply practice some if we can aware our patient during antenatal care about the danger sign of the eclampsia, danger sign of the pregnancy. Thus, we can reduce maternal mortality and infant mortality and morbidity also. Thanks to all. Now, I am hand over mic to my chairperson.
Assalamu alaikum. Welcoming you once again, the Great Obstetricals Syndrome, the session number 11. We have an eminent speaker in this session, the third speaker, Dr. Pratima Radhakrishna. Radhakrishna is the secretary, Bangalore Society of Obstetricians and Gynecologists, and she is also a director and consultant in Fetal Medicine Center, Bangalore. She will be talking about fetal demise, a challenge for obstetricians. So welcoming you, Madam Speaker, to start your session.
Salam alaikum. I understand I'm the only thing which is standing between you and lunch. So I will try my best to finish this as quickly as possible because it's indeed a challenge for obstetricians when we are faced with a sudden intrauterine death. Coming to the definition, basically delivery of a baby which has no signs of life, dedicated by absence of breathing, heartbeat, pulsations, and no definitive movements. Before 20 weeks, it's known as a delayed miscarriage, and after 20 weeks, it's known as a stillbirth. And of course, it is largely underreported, and majority of them are unexplained. And also, majority of them happen in the low and the middle-income societies, although there is a global drive to reduce stillbirths by promoting maternal health, and that is the vision of the International Society of Ultrasound and OBG as well, and the Fetal Medicine Foundation. 98% of the stillbirths occur in the low and middle income countries, and termination is not accounted as stillbirth when it is performed for anomalies. Now there are what I have described as the 10 challenges, and challenge number 1 starts from the time that we have to convey the diagnosis of fetal demise, which usually starts from the mother only because she has either reduced fetal movements or no fetal movements, and when you auscultate her, there is no fetal heart, and then the challenge starts that now you have to break the bad news. And of course, it's always good for 2 doctors to certify that there is no cardiac activity and there's no heartbeat and the baby is indeed dead. This is just as a precautionary measurement because yes, occasionally it can still happen that you don't see it very well, particularly with the high BMIs and things like that, okay? So very, very important that we convey this news very, very slow, very empathetic, because majority of the times the parents are not prepared to hear, and they're completely in distress when they hear it, and the parental needs must be addressed. It's good to hold hands, keep a hand on her hand and tell her this is what you see, and there is no better way than putting it straightforward in words that the baby is dead, the baby is no more. There is no point beating around the bush and telling them it could be this, it could be that. No, you have to be straightforward, look eye into eye and say the truth. Of course, the immediate barrage of questions, why did this happen, how did this happen, the patient is in a complete chaos and they want immediate answers, and of course we know that there are no immediate answers. We need to be effective in our communication, and unfortunately this is not a training that we get in medical colleges. We don't even get it every time we have to break bad news. It is like your first time. And there is a need to investigate the mother, the placenta, the fetus in detail before you can actually give answers, and therefore we need to take time. And I think a pause, sometimes an empathetic silence, and allow the mother, the father to react to the situation is very, very important. Then starts, the mother could be in a major medical condition, could be having a complication, and therefore the stillbirth has occurred. So abruption, hypertensive crisis, obstetric complications, this need to be treated ASAP, and then begins the workup for the cause of the stillbirth. And of course certain laboratory tests that need to be done immediately to explain the mother's condition or to give, attend to the mother's medical needs, and of course the history. Then comes delivery. The timing of delivery. Is there an immediate need to deliver? If it is not an acute condition that is affecting the mother, the delivery doesn't have to be immediate, and they can be given time to digest the news or let the news sink in and then deliver a few days or maybe sometimes even up to a week later. And then of course the debate regarding spontaneous labor versus induction of labor. Majority of the time it would be induction of labor, and we must remember the risk of DIC, although it is there and we are all petrified about it, the probability of something like that with good monitoring is less than 2%. Then comes the route of the delivery. Of course it is beyond doubt that a vaginal delivery is the best, and it can be achieved even in women who have had a previous cesarean section. Consider doing a vacuum extraction, forceps delivery. Even we need to be familiar with destructive surgery, and as much as possible try to avoid hysterotomy, because we know hysterotomy is going to compromise her future life, reproductive life, in a big, big way, and things that sometimes we cannot even imagine, particularly with placenta previa. We have heard about placenta previa, etc. this morning. Very, very important not to forget to examine the placenta, which is a very crucial part, and at least the gross examination, and consider doing histopathology, and majority of the parents will not disagree or to send a examination for histopathology, because sometimes the cause can be revealed in the placenta and then and there, and also document all these findings in the report, because many times we don't find written stuff about the external examination of the baby and external examination of the placenta. Even the weight of the baby and weight of the placenta will add big clues for the management of future pregnancies. Immediate postpartum care starts from examining the baby, the cord, the umbilical cord, the placenta, helping the parents first to connect with the baby and then separate from the baby. Both actions are very important, and many women would want to see the baby, and if we can, even if there is an anomalous baby, if we can explain to the mother this is what to expect. Some mothers will even want to hold, because these things have got long-term implications for the mother, because we do hear that, they think because ultimately the baby is her baby, it didn't make it, that's all is the difference. And if there is a need to bring in a counselor, sometimes even a geneticist, a social worker, etc., it is very important to bring them there at the time. It's a very sensitive time, but this is the best time, this is the only time rather, to discuss the possibility of autopsy and how to dispose of the newborn with due respects, and of course issuance of death certificate and postpartum, how, where they are going to be admitted, which room they are going to be admitted, can they be admitted away from the nursery. So hospitals need to have a room which is completely away at the end of the corridor, where they don't bump into other mothers who have just had their baby in a joyous mood as well. Not to forget about the breast engorgement that happens after, and then they will need treatment accordingly. Subsequent to going out of the hospital, there is an empty cradle, right? And this is very, very difficult to handle, because they go back to an empty house, and where they need to deal with a sudden grief, which was previously a joyous and anticipation of a happy moment, and now they have to deal with an empty cradle syndrome. And in these situations, it's very important to follow up them postpartum sooner and beware of postpartum depression. Postpartum depression happens even with normal joyous situations, but in these situations it could be far, far worse, and therefore it is very important to address the grief and the bereavement and give them emotional support. One point I'd like to highlight: there are situations where there are multiple pregnancies, twin gestation, where one baby is alive and one baby is dead, and every time they see the alive baby, they are reminded of the dead baby as well. So these things need to be thought about and addressed by the obstetricians. And of course, there are long-term health issues. These are independent factors, and of course, there are factors related to the stillbirth, particularly placental insufficiency, which can have long-term implications on the mother. These could just be warning signs that the mother has got some inherent health conditions, and therefore lifestyle modifications and long-term follow-up for hypertension, diabetes, cardiovascular disease, etc. is very important. Once the test results are available, you bring them back to discuss the results and make sure that everything is available, everything is ready, and they come with other supporting family members or friends and discuss the events and the possible results, the results of the possible cause of stillbirth and autopsy, and of course how we are going to handle the next pregnancy. And the key is to be well prepared for this consultation with respect to the amount of documentation that you have and the time that you give. It should be possibly the last patient in your OPD that you would see, so that you have enough time to give to the couple in the presence of your own colleague and your own friend who can be there to support, because even for us psychologically it's not an easy situation to be in. Very frequently they will ask, in fact almost always they say, what is the chances of it happening again? When they've had one stillbirth, there is a 5 times higher chance of it happening again. Of course, and therefore it is important to look into the maternal risks, the gestational age, and what were the sequence of events that actually led to the stillbirth. Sometimes the etiology is not determined, and in these cases we have to think about the possibility of abruption, preterm delivery and low birth weight in the subsequent pregnancy as well. And sometimes when the etiology is determined, like there could be specific disorders, the congenital anomalies, and then you may be able to give them some idea of what is the chance of it happening again, and then consultation has to be done accordingly. Now those stillbirth which is associated with uteroplacental insufficiency, the abruption, fetal growth restriction, preeclampsia, stillbirth, these are all pointers towards an ischemic placental disease, and therefore hopefully if you have sent a placental histopathology, you would have those results, and this will help you to tell them that the chances of preterm delivery or SGA baby in the subsequent pregnancies is higher, and therefore we need to monitor those pregnancies much more carefully. And if they've had a previous SGA, term SGA, preterm SGA and very preterm and SGA, the chances of stillbirth in subsequent pregnancies goes up significantly. And finally, how do we prevent a recurrent stillbirth? And the key lies in having had thoroughly evaluated the first stillbirth, preconception management to prepare them for the subsequent, for the upcoming pregnancies. And of course, if there are any medical reasons, then screen them, screen for diabetes, low-dose aspirin, we heard about low-dose aspirin in preventing preeclampsia, use of low-dose aspirin if there are signs of placental insufficiency, and extremely important, yesterday we had a discussion about this as well, to avoid using unnecessary medications in the pregnancy. Be honest to them, tell them what was the possible, and avoid using randomly anticoagulants and other things in the hope that you may be able to prevent stillbirth again. Good close monitoring and good timing of delivery, not too premature, but also be reassuringly good to the patient. And finally, to summarize, empathy, honesty, efficiency, and definitely backed up with evidence-based medicine is what is needed in, first of all, diagnosing, breaking bad news, and finally to prevent stillbirths from happening, preferably even the first time, but certainly recurrence of preterm delivery. Thank you very much.
Thank you very much, Madam Speaker, for your nice and comprehensive talk on fetal demise. Fetal demise, actually this is a great challenge for us, a challenge to break the bad news, at least by the help of two operators. There are so many queries, so many questions on the part of the patient, her husband, relatives. We have to prepare ourselves to answer those. So there is strengthening of communication skill with proper documentation. And we are trying our best. At least we cannot prevent completely pre-eclampsia, but we should be trying our best to prevent severe pre-eclampsia and eclampsia with the help of today's speech. So many things we are now hearing from this session, a great magic with low-dose ecosprin. Already we are hearing about the use of low-dose ecosprin and patients' empowerment by self-monitoring, self-reporting, improvement of our network communications, and obviously a proper referral system. We shall try our best. Thank you very much.
Dear audience, thank you all for patience and hearing. Now we are at the end of the session. I would like to request the chairpersons to give the certificate of appreciation to our speakers. Professor Shahin Rahman Chaudhary will give certificate to T.P. Bhaskaran, Dr. T.P. Bhaskaran. And I would like both Professor Shaila Jasmine Madam and Professor Afroja Kutubi Madam to give certification of appreciation Dr. Pratima Radhakrishnan. Dear audience, we are very glad that the first and the only book on high-risk pregnancy was written by our renowned and respected Professor Firoza Begum Madam, pioneer of Maternal and Fetal Medicine Society of Bangladesh, are ready to deliver to our chairpersons. And I would like the chairpersons to give the book each other. Hey, Asho. Yeah, Asho. Asho. Asho, Asho.
We feel privileged to thank our chairpersons for conducting the session successfully. Thank you, madam. We are also grateful to our speakers for their informative knowledge sharing, which enrich our knowledge enormously. Thank you. We'll try to enjoy their knowledge and recommendations and experience in our field. We also thankful to our participants to make the conference fruitful. Now this is the time for lunch. Before lunch, please keep patience. There is a raffle draw. Please wait and sit down. And the raffle draw will be organized by Square Pharmaceuticals.
I want our fellows who have just passed on the dais so that they can pick up the draw for the audience. They can draw the coupon. Who have passed, please all come on to the dais. ওই দিক থেকে দাও। I think they need a great applause for their passing in the exam. So we will start from the 10th one. There will be 10 prizes. We'll start from the 10th one. Okay. So first, go. Tell your name.
Dr. Naushafrin Choudhury.
Just pick the one, first one. Who is the lucky one? See. Quick. 012. Geston. Is there anybody? Zero, 1, 2. Geston. Please rapidly come to the dais. আচ্ছা 10টা পুরস্কার, ইচ পুরস্কার হলো 10,000 টাকা, নট রুপি। And the first one is 50,000. আচ্ছা আপনারা এই ফাঁকে একটু কি দিয়ে ফেলেন।
আমাদের এটা গিফট কুপন আছে, আপনি যেখানে প্র্যাকটিস করেন আমাদের স্কয়ার কোয়ালিটি এটা ট্রান্সফর্মারে আছে, এর সাথে আপনি অ্যাড করে কুপনে ইউজ করেন। কংগ্রাচুলেশন ম্যাডাম। আমাদের
তাড়াতাড়ি উঠো, তাড়াতাড়ি কুইক। পড়ো 380 না?
Geston 380.
380. Geston 380. It is also 10,000 taka. Sabirapa is eagerly showing his things. Acha. 1, 2, 3. Done. Next. Na arekjon asho. Next ke?
380
না আসো। তো আওয়াজ দিতে হবে, না হলে তো শেষ হয়ে যাবে। 380 is anybody here with 380 from Geston? 1, 2, 3. That's it. ওঠো আসো। নেক্সট কে আসো। আচ্ছা নিজে পরিচয় দাও।
I'm Dr. Raunak Jahan. 4 middle to 747.
নিজেদের গুলাও চেক করেন। 747. ও বাবা, হ্যাঁ, ডক্টর বেগম নাসরিন, প্রফেসর বেগম নাসরিন, চেয়ারম্যান অফ অবস অ্যান্ড গাইনি, বঙ্গবন্ধু শেখ মুজিব মেডিকেল ইউনিভার্সিটি। একটা আমার কাছে দেন। আচ্ছা তুমি দাও, যে উঠেছে, কে উঠেছে না, যে উঠেছে সে দাও। শ্যামা মাঝখানে আসো। আচ্ছা ইন দ্য মিডল। আচ্ছা
সেকেন্ড পুরস্কার আগে বললো।
আসো না, তোমার পরিচয় দিয়ে তারপরে বলো। ভিতর থেকে উঠাও। A great round of applause for our fellows at least. Okay.
1, 2, 3.
2, 3, 1.
আচ্ছা আমি উল্টা করে বলেছি 2, 3, 1. Geston 2, 3, 1.
2, 3, 1. Is anybody there? একটু হাত উঠান।
2, 3 on আমার বলেন।
231.
1, 2, 3. It is dropping down. তুমি আরেকজনকে দাও। আসো। এবার তুমি
এটা বোঝা যাচ্ছে না, এটা সরাই। 995
জি জেস্টন 995
তোমার পরিচয়টা দাও।
আই এম ডাক্তার মার্জিয়া
995 এটা রাখো এটা ধরো। আসো সামনে আসো, এখানে দাঁড়াও। পরে কে তুলবে? দাঁড়াইছে। ফাইন, নেক্সট। এটা কত নাম্বার হবে?
এটা ইটস মেবি 4
মেবি 4।
আমি ডক্টর শেহনীলা, the last number 8, first 9 and the middle one is 4. 948. 948. 948. The one, two.
948 কেউ নাই? ওকে, পাস। নেক্সট, আসো। সুচি আসো। Tasneem, are you there?
Hello. Geston 224. Geston 224.
224, please. Rush to the dais.
1, 2, 4, 3. আচ্ছা, ওকে, চলে আসছে।
224, আচ্ছা, এদিকে আসো। আচ্ছা, দাঁড়াও, আসো। পরে কে আসবে? আচ্ছা, সামনে দাঁড়াও। কই? কোথায় আছো এটা একটু বলো।
আমি ডক্টর রোকসানা পারভিন, আমি এফসিপিএস পার্ট 2 কোর্স স্টুডেন্ট হিসেবে বিএসএমইউতে আছি এখন।
তোমার টিকিটটা দাও, আমি যাবে। ঠিক আছে। আচ্ছা, বিফোর গোয়িং টু দ্য নেক্সট কুপন, there are some representatives from the square. They will give their identity.
Thank you all. I am from Square, and we all basically. Thank you for your patience, time, and give us opportunity to give some excitement from our side. We are always with you and be with you. So let's good wishes for us. Thank you very much. Thank you.
আমি ডক্টর উমেশ সালমা, আমাদের নাম্বার হচ্ছে জেস্টন 1049. 1049.
$10,000 টাকা, ইটস অলসো 10,000
কত
এটা ফিফথ গেল ম্যাডাম।
হ্যাঁ, এটা কত বলেন?
10,000. 10 আসছে
কোথায়? 1049. ওকে, 1049। আসো, দাঁড়াও রাজশ্রী, দাঁড়াও, না আগে দাঁড়াও। 1049। ও বাবা, আসো সামনে, আসো পরিচয়।
নমস্কার, আমি ডাক্তার স্মৃতিকণা বিশ্বাস, মেডিকেল অফিসার হিসেবে 250 বেডের টিবি হসপিটালে কর্মরত আছি এই মুহূর্তে।
ঠিক আছে, নেক্সট।
ফিফথ গেল। আপনারা উল্টো দিক থেকে যাচ্ছে।
জেস্টন 1196.
1196, Geston 1196. আচ্ছা, এদিকে চলে আসো, ওর হাতে দুটো দিয়ে দেন।
আর কয়টা আছে আপনার কাছে? 4টা।
থ্যাংক ইউ বলতে হবে আমি ডাক্তার ডালিয়া রহমান অ্যাসিস্ট্যান্ট প্রফেসর ঢাকা মেডিকেল কলেজ ইটস আ গ্রেট প্লেজার টু মি যে আমি এই র্যাফেল ড্র উইন করলাম থ্যাংক ইউ ভেরি মাচ ছবি তুলবে
আচ্ছা Now the fourth prize is 20,000 taka. And
It is Geston. I'm Dr. Tasnim. It's Geston 117. And prize is 20,000.
117. বাবা আমার হাতে তুলেন না কেন তুমি ওর পাশে চলে যাও ওর পাশে যাও
আমি কিন্তু কুপনটা দিছি আপনার হাতে
ওনাকে দেন একটু পরিচয় দিতে একটু পরিচয় দিতে বলো
আমি কিন্তু কুপনটা দিছিলাম ম্যাডাম ঠিক আছে
আসসালামু আলাইকুম আমি ডাক্তার হাসানাত জাহান কনসালটেন্ট ছিলাম মানে অবসরপ্রাপ্ত পাবনা জেনারেল হাসপাতাল থ্যাংক ইউ
এবার 30,000 টাকা ম্যাডাম থার্ড পুরস্কার
But the third prize 30,000.
Dr. Mahfouza Asma, third prize 30,000 taka, serial 392, product name Geston.
Geston 392. 30,000, na? 30,000. Don't miss it. Who has got it? Okay. 392. 392. 392. সবাই বলছে এটা ড্রপ করে দিতে দিব 392 লাস্ট কল so it is dropped again the third prize and it's Arifa.
আমি আরিফা শারমিন নিজেরটার সাথে একটু মিল ছিল বাট একটা মিস হয়ে গেছে আমারটা 738 আর এখন যে প্রাইস পাবে সেটা হচ্ছে 728 anybody here Geston 728 সুরভি আপা
কেউ যদি নিজেরটা নিজে উঠাতে পারো এক্সট্রা আরো 10,000 টাকার পুরস্কার
টাকা 30,000
আমি ডক্টর আসমানি জানা মেডিকেল অফিসার অফ ফিটোমেটার্নাল মেডিসিন অলসো রেসিডেন্স একটা ছবি তুলেন
The second prize টাকা 40,000 আর এখন ঘোষণা আসছে নিজেরটা নিজে তুলতে পারলে আরো 10,000 so দেখেন কেউ কারোটা
Second prize, Geston 812. 812. Geston 812. Taka 40,000 second prize.
40,000 হলে তো এত আস্তে আস্তে আসলে হবে না দৌড়ায় আসতে হবে you have to run
আমি ডাক্তার গৌরী রানী দাস আমি অ্যাসিস্ট্যান্ট রেজিস্ট্রার মুগদা মেডিকেল কলেজ
The first prize 50,000. Down. The first number one. Last number 8. First number 1, last number 8. Second number 0. Third number 5. 1058. It is from Geston. 1058. Okay. Wow. Second time. ওরে বাবা পাইলে কিছু করার নাই যাও
আচ্ছা ফার্স্ট প্রাইজ 50,000 টাকা আমি তো ইচ্ছা করে নেই নাই ম্যাডাম আমি ডাক্তার নুরজাহান বেগম এম এ স্টুডেন্ট বারেম একাডেমিতে আছি
আচ্ছা
ম্যাডাম উনি আমাদের হরমোন প্রোডাক্টগুলো দেখেন আর থ্যাংক ইউ ম্যাডাম এই রূপা ম্যাডাম ওদের প্রোগ্রাম তুমি করছেন